I will teach you how to interpret the normal chest X-ray. Then also I will go through what are called abnormal chest X-rays, abdominal X-rays, so on and so forth. So, but mainly concentrating on chest X-rays. All right. So let's go through one by one. Now, now this is the normal chest X-ray. I have uploaded this all these slides to your WhatsApp group. So, like you can open your iPhone, the WhatsApp group, PDF files, and you can go through these images. So, guys, that day I taught you how to interpret a chest X-ray. When you are interpreting chest X-rays, so in a chest X-ray, what are the main areas? You have the lungs, you have the mediastinum, right? Mediastinum is what is there right in the center. What is the most important structure of the mediastinum? It's the heart. Then you have the trachea, which is divided into two main bronchi. Then you also have the vessels, from which is arising from the mediastinum. You have the aorta, you have the two pulmonary trunk, pulmonary arteries. And also in this hyla area, you can get lymph nodes, right? So those are the structures in the mediastinum. Then guys, in this mediastinum upper part, you can also see a gland called thymus gland, very difficult to mention or see that in a normal chest X-ray. Then also if you got a large goiter that will come down to the thorax, what we call retrosternal extension of the goiter, then the goiter also can be seen in the in this area. So lungs are there, the two lungs, then you have the mediastinum, then you have the bones. So you have the ribs. Now posterior, because when you take a chest X-ray, you take from behind. So the X-rays are coming from backwards. So the posterior ribs are going like this horizontally. You can see these are posterior ribs which are going horizontally. And the ribs which can see very prominently are the posterior ribs, right? So these are posterior ribs. So you have to see whether there are any fractures or whether there are any lytic lesions. Like what are lytic lesions? Black colored holes in the ribs. You have to see whether that type of thing is there, right? Then also that you have to count the anterior ribs. Now these are the anterior ribs which are going in an oblique way like this. You can see here first rib, second rib, third rib, fourth rib, fifth rib, and sixth rib. So like usually in a normal person, above the diaphragm, there are less than 7 ribs. But if you got more than 7 ribs anteriorly, which is going oblique way, if you can count more than 7 ribs anteriorly, that is a feature of COPD, or what you call air trapping. All right. So these are the anterior ribs. This side also you can see anterior ribs faintly, they are going in an oblique way here. Can you see? Those are anterior ribs. So you have to interpret on the ribs. Then also you have to look at the clavicles, these two clavicular bones, see whether they are fractured. You can get clavicular fracture here, right? This is what you call the collarbone. This is your collarbone or the clavicles. You can get fractures there. And also sometimes you can get lytic lesions from multiple myeloma or metastatic deposits. So you have to look into that also. Then the other structures are the scapula. The bony structures are scapula. These are the scapula. Then guys, you have the soft tissues. So soft tissues here in the neck area, you have soft tissues. On the lateral aspect of the chest here, these areas, you can see the soft tissues. And also you can see soft tissues as your breast shadow. Then the other important structure is your diaphragm. So this is the left hemidiaphragm, this is the right hemidiaphragm. Okay. So this usually the right hemidiaphragm is above the left hemidiaphragm. Right hemidiaphragm is above left hemidiaphragm. And you must always see whether there is any gas under this right hemidiaphragm. So if you got any gas shadow, like which will be seen as a black colored shadow. So if there's a gas shadow below the right diaphragm, then you call it a gas under diaphragm, and that is a very important surgical emergency. Why? That is due to perforation of a viscous or a hollow organ, maybe a perforated appendix, maybe a perforated bowel loop, something like that. Okay, so you have to look into that. Then on the left side, you can see the gastric air bubble, which is normal. That's the stomach air bubble, and it has to be there on the left side. It's a normal finding. Then guys, you can see two angles here. One angle is here, another angle here. What do you call that? Now, costo means ribs, phrenic means diaphragm. So this is called the right costophrenic angle, right? Costophrenic angle. And there should be a nice arrow, a nice angle like this. It's a pointed angle, right? And this should be black. Why? It's filled with air. Now, if it is blocked and if there's any white color, that is called obliteration of the costophrenic angle. If this is filled in white color, that is called obliteration of costophrenic angle. And this obliteration of the costophrenic angle, that happens when you get a pleural effusion. Just give me a second, please. Yeah, so that happens in a pleural effusion. So when you get a pleural effusion, the costophrenic angle, that will be obliterated, correct? Right. Okay. So those are the things that you have to see in a normal chest X-ray. So you have to look at the lung fields, you have to look at the mediastinum, you have to look at the ribs, you have to see the clavicles, scapula, and also the soft tissue shadows, as well as the diaphragm and the structures below diaphragm. These are the things that we are going to interpret in the chest X-ray. So here you can see this is another picture of normal chest X-ray. This is also another normal chest X-ray. You can see lung fields are basically seen in black color. Why? The lungs are filled with air, and air will be seen in black color. But the vascular markings can be seen. Can you see that there are faint vascular markings which can be, so those are like very tiny white streaks which are going to the periphery of the lung. And in a normal lung, you need to see these white streaks, very tiny, faint white streaks going up to the periphery of the lung. So it's not pure jet black. Why? If it is pure jet black, no vascular markings, it's just air, and that happens in pneumothorax. But in a normal lung, you can see these faint white streaks, streaky shadows going to the periphery of the lung, and that represent normal lung and normal vascular markings, because all your lungs, they are having vessels, blood vessels, right? And this is another normal chest X-ray. You can see the lung fields, then you can see the mediastinum. And also, guys, that day I told you, when you look at this mediastinum, you also have to take the cardiac ratio and also the thoracic ratio. So normally the cardiac width, this is the cardiac width, that is less than 50% or less than 0.5 of thoracic width. This is the thoracic width. So in other words, if you get cardiomegaly, the cardiothoracic ratio, so the cardiac shadow divided by the thoracic ratio, that will be more than 0.5. All right. So you need to look into that. Whether the cardiothoracic ratio is less than 0.5, that is normal, more than 0.5, that is abnormal. That happens in cardiomegaly and heart failure. All right. So that is normal chest X-ray. Then there's another picture of normal chest X-ray. Look at this one. So you can see the lung fields, they are seen in black color predominantly, but you can see the white streaks going to the periphery. There's normal lung markings. Then this is the mediastinum, and the cardiac shadow is less than half of the thoracic shadow. And you can see the trachea is coming in the center. There is divided into two main bronchi, which is normal. These are pulmonary arteries, which is normal. And then you can see the rib shadows posteriorly like this, the anterior rib shadows going like this in oblique way. Okay, there are no fractures, clavicles, the scapulae, and then you can see the costophrenic angles. Then the diaphragms on the right side is nicely elevated than the left one, and you can see the left-sided gastric air bubble. So it is a normal chest X-ray. So now, having discussed the normal chest X-rays, we are going to see how to interpret abnormal chest X-rays. Abnormal chest X-rays. Let's do that. Now, first I am going to teach you a condition called pneumothorax. It's a medical emergency as well as a surgical emergency. So what is called a pneumothorax? What's a pneumothorax? Right? Now, pneumothorax is a condition where you have, so pneumothorax is a condition where you have gas or air filled in the pleural space. Now, usually in you and I, we have two lungs. Lungs, the outer covering is called visceral pleura. Then the inner cover of the thoracic cage, that is your rib cage, is called parietal pleura. So between the parietal pleura and the visceral pleura, there's a very thin rim of fluid. Why? They need to slide on each other. When we take a deep breath in, You saw how I was inspirating and expirating. Inspiration of thoracic cage moves out, it expands. And when you expand, this parietal pleura and visceral pleura, they slide on each other. For that, you need to have nice, smooth movement. For that, you have a thin rim of fluid. But if you got air between this parietal pleura and visceral pleura, there is gas in the pleural space, and that is called pneumothorax. Pneumothorax. You also can get too much of water, too much of fluid in this pleural space. Then what do you call that? Pleural effusion. Pleural effusion. Sometimes there's pus, there's dirty, neutrophil rich, protein rich, bacteria rich substance which is yellowish or thick pus, ceraba. So when you got pus in the pleural space, you call it empyema. Empyema. You also can get blood, certain condition can cause bleeding into the pleural space between these two spaces, parietal pleura and visceral pleura. And that is called hemothorax. That's called hemothorax. Then also in certain conditions like, damage to the thoracic duct. What is thoracic duct? The duct which drains the lymphatics. We have lymph nodes, we have lymphatics. From the lymphatics, they drain to the venous system. So thoracic duct is the connecting channel. So when this thoracic duct get blocked, sometimes that lymph can get drained back into the pleural space, right? So when there's a lot of lymph in your pleural space, that is appearing, that is just looking like a white colored or milk colored fluid. It's like just pure milk, white. And if you analyze that, there's a lot of cholesterol in it, and that is called chylothorax. So these are the different types of conditions that you get in pleural space. So air, pneumothorax; water, pleural effusion; blood, hemothorax; pus, empyema; and then pleural, the cholesterol rich fluid due to lymphatic drainage, that is chylothorax, right? So the first thing that we have to diagnose is pneumothorax, air in the pleural space, very dangerous condition. So what are the clinical features of pneumothorax? Now, if a patient present with pneumothorax, they come with sudden onset or acute onset, severe shortness of breath. The cardinal symptom or the main symptom is acute onset. The patient had been all right before. Patient like that, acute onset, shortness of breath, very dyspnea. There are three conditions which make you acutely dyspneic. There are three conditions which make you acutely dyspneic. What are they? One is pneumothorax. The second one is acute pulmonary embolism. So if you got an acute pulmonary embolism, you can get severe shortness of breath. And the third condition is acute pulmonary edema, acute pulmonary edema. So these three conditions, you will be acutely dyspneic. So acute tension pneumothorax, acute pulmonary embolism, acute pulmonary edema. So in these three conditions, you can have acute shortness of breath or what you call acute dyspnea. So here in acute pneumothorax as well, the patient is acutely dyspneic, right? They have acute shortness of breath. So how to recognize that? And what are the other features of pneumothorax? Is not only acute dyspnea, they are also they have increased respiratory rate, they are tachypneic, and also their heart rate is high. So they have tachycardia. And when you get a severe pneumothorax, why? This air compress on the heart. So the heart contractility is reduced. So you get low blood pressure, right? You get low blood pressure. And so these are the conditions of tension pneumothorax, all right? And due to this pneumothorax, because if I have got a pneumothorax on my left lung, due to that pressure from there, the trachea will be pushed to the opposite side. So trachea will be like this, it will be kicked to the opposite side. So tracheal deviation also can be there in a tension pneumothorax. It's a dangerous condition. Patient can die instantly like this. How do you treat that? So you don't need any magic equipments, magic investigations. You just take a large bore needle, like the blood needle. What is blood needle? The needle that you use, the cannula that you use to transfuse blood to a patient. It's a large bore cannula, large bore cannula, like maybe 14 gauge or 15 gauge, something like that. So you take that needle. So like when you percuss, how do you diagnose pneumothorax? On physical examination. So if I got a left-sided pneumothorax, when you percuss my right lung, you know, this is the resonant percussion node. There's resonant percussion node. But when you got pneumothorax, that resonance will be exaggerated because there's too much of it. So that is hyperresonant. So the resonance is the normal finding, but if you got pneumothorax, you get what is called hyperresonant percussion node. So the patient will have hyperresonant percussion node, and the respiratory rate is so high, the pulse rate is so high, blood pressure would be low, and the trachea will be shifted to the opposite side. All what you got to do is take a needle from on the side where patient got hyperresonant percussion node. You usually use the upper second intercostal space. So like this is my, now this is my sternal notch, suprasternal notch. So if you come down like this here, I can feel my angle of Lewis. So the space just next to that is second intercostal space. Usually you go through the second intercostal space, upper second intercostal space, and usually you don't go right in the center, but usually you go from the lateral side like this. You take this needle and just prick the chest wall like this. And as you prick, what happens? The gas goes out. That pressurized air goes out of the lung, and you will hear the gush of air. Psss, that sound will come. And with that release of air, the patient's condition will come back to normal, right? Patient's tension is relieved. Blood pressure will return back to normal. Heart rate will come down. Respiratory rate will come down. Saturation will improve, and his dyspnea settles. That's the immediate measure, right? So what is that called in scientific terms? Needle thoracostomy. Needle thoracostomy. All right, and you can also connect that end of the cannula uh, to a catheter, and you can put it in a beak of like a kidney tray, and into that you can fill some water, and you can put the other end of that catheter wire into that water beaker, and you can see the air bubbling through that. So then for sure you know the tension pneumothorax, you have relieved it, you have got the air out. Okay, so that's how you treat pneumothorax. Then after that you take a chest x-ray. So chest x-ray you don't do immediately. There's no time to do chest x-rays because patient is so sick, unwell. It's a life-saving procedure, needle thoracostomy. So after that, you do a chest x-ray and find out where the patient has got pneumothorax, and then you insert an intercostal tube. So for that, you call the surgical team or the cardiothoracic team, and they will put a nick here, and they will insert the intercostal tube, and then they will drain it to underwater seal. Right. Before all that, in a chest X-ray, you need to identify. So I told you the clinical features of pneumothorax, how to diagnose pneumothorax clinically. But you also need to identify pneumothorax in a chest X-ray. How do you do that? Now look at this. Now see, when you see this left lung field, look at the left lung field. The left lung field from apex to the base and the costophrenic angle, you can see the white streaky lung shadows. So these are nice vascular markings. Can you see the white shadows? So majority of the lung is black, but you also can see the white streaks of pulmonary vessels going to the periphery. So that is normal left lung field. But look at the right lung field. In the right lung field, the lung is like this. Can you see? Just follow my arrow. So the lung has been collapsed towards the mediastinum. Why is that? Because there's so much of air. Can you see this area is all black? This is all black. So this area is black, and that black air in the pleural space has caused pressure on the, so this is the parietal pleura, this is the visceral pleura. So this huge amount of air is causing pressure on the lung, and the lung has been collapsed towards the mediastinum. It's collapsed towards the mediastinum. So this is the lung. You can see the lung markings only up to this level. So this is the huge pneumothorax in this patient. It's a huge right-sided pneumothorax. All right. So let's go to this picture, the right upper corner. This is another picture of pneumothorax. You can see this is the left lung, which is normal. The right lung is collapsed towards the mediastinum. Can you see the right lung border? It's going like the right lung border. And this, where I am shading with this arrow, that is the area of pneumothorax. You can see black air without any lung markings. Those white streaky shadows that you saw here, white streaky shadows that you see here are not seen in this black area, not seen in this black area. So it's purely black and there are no white streaky shadows of lung markings. So that is called a pneumothorax. So all what you've got to do is you take the needle, go through this space, and put in here laterally, and that's called needle thoracostomy. Then after some time, you insert a IC tube. Look at this right low down chest X-ray, and here you can see the right lung is normal. You can see the black shadows and also which is normal, and also normal lung markings, vascular markings up to the periphery. But look at the left lung field. You can see very clearly in the left lung, the lung is collapsed towards the mediastinum. This is the lung border. This is the left lung border. Left lung border is going like this. Can you see this? It's only up to this level, right? So lung is here. And this area, this sort of triangular area is all air, just blackish. So all black, and that is air. So that's again a pneumothorax. So it's the low down picture is left-sided pneumothorax. So here what you do is you take a needle and go through this space here on the left lateral side, left upper second intercostal space laterally, and you allow the air to go out, right? So now you guys know how to identify a pneumothorax in a chest X-ray. So what is the key message? In pneumothorax, there are no vascular markings. It's all black air that you can see, and not only that, you also can see the collapsed lung margin. Here, this is the collapsed lung margin. Here, this is the other collapsed lung margin, and here this is the collapsed lung margin. And then the rest of the space is all air, and that is pneumothorax. So this is how you perform the needle thoracostomy. You can see you on the side of the pneumothorax, you select the upper second intercostal space, and little more laterally you go through that space, and that is called needle thoracostomy. You can see this is the place, second left intercostal space. You can see over the third rib, second intercostal space. Either you can use the mid clavicular line, or I prefer to go little laterally, then you are even safer. So you can see how you do the needle thoracostomy. So here this patient has got air, and you go to this space and relieve that air. All right, and that is called needle thoracostomy, life-saving procedure. So after performing the needle thoracostomy, then you have time, because you know for sure the patient is not dying. Then you can take a chest X-ray leisurely, identify where the patient has got, which side patient has got pneumothorax, and also see whether it's a very tiny pneumothorax or a large pneumothorax. For a tiny small pneumothorax less than 2 centimeters, you don't have to do anything. But if it is a large pneumothorax, then you must do a intercostal tube drainage, IC tube. So this is how you insert an IC tube through this second lateral aspect of the chest wall. You insert the IC tube and allow it to place in the pleural space, and the other end of the IC tube you send to a water bottle, and this is called underwater seal. You can see, so this is the area of the this is the pleural space. Yeah, here you can see air, and this is the catheter, IC tube catheter, and here you can see it's going to this bottle, and it is underwater seal. So if you got air here, the air will be bubbling through this water, and you can see that air is bubbling through this water, and then it comes to this space, and then then there's a small another tube which communicates with air, and then it combines with the normal air pressure. All right, so this is called this mechanism is called underwater seal. So always when you drain a pneumothorax, you have to keep the patient at a higher level, and this bottle, the underwater seal, has to be kept below the patient's level, right? Below the patient. You can see here, this is the patient. Here you have put the IC tube, and this is draining, and here there's another IC tube. It's been drained like this, and can you see this is the bed level, and the Redivac bottle, or the underwater seal bottle, will be kept on the ground, right? Because it has to be below the patient's level, so then only the air will go through that and will bubble through water, right? So this is the treatment of pneumothorax. What are the causes of pneumothorax? causes of pneumothorax. So pneumothorax can occur due to several reasons. The commonest cause of pneumothorax is the trauma, like during road traffic accidents, during blast injuries, during stab injuries. Road traffic accidents, blast injuries, and also stab injuries. Then you can get air leaked into the pleural space. So those are called traumatic pneumothorax. You also can get medical conditions leading to pneumothorax. What are they? If you got bronchial asthma or COPD, they have what are called bulla, large bulla, air-filled spaces. They can rupture, and when they rupture, that air will leak into the pleural space, and that can cause pneumothorax. So bronchial asthma patients, COPD patients, they are prone to get pneumothorax. Not only that, certain connective tissue diseases, they have high risk of getting pneumothorax. Guys, you need to remember these are MCQs. Certain connective tissue diseases, they have high risk of getting pneumothorax. One particular disease is called systemic sclerosis, or what you call scleroderma. Systemic sclerosis or scleroderma, and that has increased risk of spontaneous pneumothorax. So no trauma, just all of a sudden they develop pneumothorax. Another condition which can cause spontaneous pneumothorax is when you get Marfan syndrome. So these Marfan syndrome patients, they also can get spontaneous pneumothorax. We also have seen in Oriental males, tall, thin Oriental males, they particularly describe this in Asian males, maybe Chinese, maybe, you know, tall, thin males. Sometimes they also can get spontaneous pneumothorax. A question on pneumothorax was given in ERPM best of 5 paper. So you need to know that. Okay. So I have given you causes of pneumothorax. I have discussed clinical features of pneumothorax. I have taught you X-ray findings of pneumothorax. I have taught you the immediate management of pneumothorax, which is needle thoracostomy. I have taught you the long-term management of pneumothorax, that is inserting an IC tube and connecting to a underwater seal. Okay, so that is pneumothorax, very important topic. Right. Next topic is water. So now earlier we discussed air in the pleural space. Now we are going to discuss water in the pleural space. So water in the pleural space is called pleural effusion. Water in the pleural space is called pleural effusion. So when you get a pleural effusion, remember guys, there's a rule in X-ray. What is that? Always air appear in black color. Air appear in black color in the chest X-ray. Okay, not only chest X-ray, even the abdominal X-ray, wherever air appears in black color. Fluid. So what are the fluids? Water, pus, blood, lymph, like that. The fluid appear in white color. What about the bones, which contains calcium? So whatever calcified lesion, or when you have calcium, so calcium is mainly containing in bones. So if you got calcium or bones, they appear even whiter. So they have very bright white color. Okay, so black, white, whiter shadows. Okay, so bones are very, they are appearing in very bright white color. Okay, so here pleural effusion is water, so it should appear in white color. So what is the first place here where you will notice pleural effusion? Guys, lungs, when you take lungs, air usually stays in the upper part. Why? Air is very light, but water will go down in the thoracic cage. So if you got a pleural effusion, it first starts in the bottom of the lung field. So what is that place called? Costophrenic angle. Costophrenic angle. Here, this angle. Now you can see on the right lung, costophrenic angle is beautifully preserved. But what has happened in the left lung? In the left lung, the left costophrenic angle is obliterated. This angle is not there in this left side. So that is left-sided costophrenic angle is obliterated, or it's blocked. And also is blocked with white color shadows. So what is this? A pleural effusion. So pleural effusions, they cause white color shadowing, and that will block or obliterate the costophrenic angle. So this is a left-sided pleural effusion, which is shown up in white color. And not only that, when you get to pleural effusion, you can see that it ascends up. Can you see this sketch diagram? Here you can see this is the normal left lung field and this is the right lung field, and here in the pleural space there's water. And when there's a pleural effusion, usually in the X-ray you see it's like this. You see a meniscus like this. And it goes in a curvy manner, like it's just a curve upwards. Can you see? There's a curve upwards, not always there, but most of the time this curve can be seen going to the uh, uh, top of the lung field. Can you see a curve going upwards? So that is called meniscus sign. Meniscus sign. Okay. So here this is a left-sided pleural effusion. And here you can see a patient again who would have come with shortness of breath. His left lung fields are normal, cardiac shadow is normal, and his right lung, you can see the lung markings only in the upper part. Rest of the lung fields, you can see only white color shadows. So what is that? It's a right-sided, it's a large one. This is a small one, but this is a large right-sided pleural effusion. And you can see the meniscus sign here. Meniscus sign. All right, so this is a moderate right-sided pleural effusion. Then this is another good example of a left-sided moderate pleural effusion. You can see the right lung field is complete normal, but when you take the left lung field, you can see the left costophrenic angle is blocked, is obliterated, and you can see this homogeneous white opacity is the fluid which is filling the up to the left mid zone, and you can see this curved margin going up. So that is the meniscus sign. So this is again a moderate left-sided pleural effusion. So this is the diagrammatic explanation of pleural effusion. You can see the lung is compressed up and also this meniscus sign. Guys, what are the clinical features of a pleural effusion? Clinical features of a pleural effusion. So the patient usually presents with shortness of breath, dyspnea, pleural effusion also present with dyspnea. Sometimes they might complain of dull aching pain on that side of the pleural effusion. Why is that? There's a lot of water, so heavy lungs, heavy thoracic cage, and that might cause dull aching pain. But usually they present with shortness of breath. All right, pleural effusion usually present with shortness of breath. Guys, remember pleural effusion can occur over few days, like following a pneumonia, and also it can occur as a chronic condition. Like you can get chronic pleural effusions, like tuberculosis, then various connective tissue diseases like rheumatoid arthritis, SLE. It can occur as a very slowly progressive thing. In malignancies also, the pleural effusion will occur as a slowly progressive thing. But after a pneumonia, the pleural effusion can occur suddenly like this. That is called sympathetic effusion or a parapneumonic effusion. All right. So, yeah. So, what are the clinical features? I told you the history. They will present with shortness of breath. It can be either acute over a few days, or it can occur over few months, like in tuberculosis. Guys, when you get a pleural effusion, what are the causes of pleural effusion? You need to know the causes of pleural effusion. So for you to identify the causes of pleural effusion, they are divided as exudates and transudates. They are divided as exudates, which is rich in protein and rich in LDH, that's called exudate, or transudate. Transudate is low in protein, low in LDH. So for us to differentiate exudate versus transudates, we use a criteria. We take this pleural fluid. So as doctors, we always, when there's pleural fluid, we prick it. So you can see here we do needle aspiration. We pop in a needle to his pleural space, but we make sure that we don't prick his lungs. We only prick the pleural space, take out fluid and analyze that fluid. So what are the things that we analyze here? You can see another pleural effusion being carried out via a three-way tap. This is what we usually commonly do in the wards. Sometimes you also can do ultrasound guided aspiration of the pleural fluid, particularly for small ones. These are for the big ones. So in the pleural fluid, you examine the proteins, pleural fluid protein or albumin. You also check the pleural fluid LDH. You also analyze the pleural fluid for cytology, whether there are white cells, or what you call polymorphs, whether there are lymphocytes, whether there are red cells, and whether there are malignant cells. All right. Then also this pleural fluid you can send for culture, gram stain, acid-fast bacilli for tuberculosis. And not only that, this pleural fluid, from the pleural fluid, you also can do TB PCR to diagnose tuberculosis. And also another important is called ADA. What is ADA? Adenosine deaminases. So adenosine deaminases levels are particularly high in tuberculosis. In tuberculous pleural effusions, adenosine deaminase levels, or what you call ADA levels, are very high and very sensitive. Right. So I'll just teach you how to differentiate pleural effusions as exudates and transudates. Now look at this. If it is an exudate, your pleural fluid protein divided by the serum protein, it has to be more than 0.5 for you to call it an exudate. Why? Exudates are which are rich in protein. So that means too much of proteins in pleural fluid. So the pleural fluid protein should be more than half of serum protein or blood protein. Then it's a exudate. So what we do is we take the pleural fluid protein divided by serum protein, or pleural fluid albumin divided by serum albumin, and the ratio should be more than 0.5, and that's an exudate. If the ratio is less than 0.5, then you call it a transudate. Then you take the pleural fluid LDH. If the pleural fluid LDH is high, that happens in exudate, and the pleural fluid LDH is low in transudate. So we take the pleural fluid LDH and divide that by serum LDH. And if the ratio is more than 0.6, you call it a exudate. The ratio is less than 0.6, you call it a transudate. There's another way of differentiating exudate and transudate, a simple way. It's even easier than the method that I told you earlier. The method that I told you earlier is called Light's criteria. Light's criteria. So if your pleural fluid contains more than 30 grams per liter, what is the value? More than 30 grams per liter, it's an exudate. If your pleural fluid contains more than 30 grams per liter of proteins, it's an exudate. If it is less than 30 grams per liter, transudate. If your pleural fluid contains LDH more than 200 international units, it's an exudate. If your pleural fluid LDH is below 200, then it's a transudate. All right. So what are the examples of transudates? What are the examples of exudates? So the examples of transudates are heart failure. You know, in heart failure also you can get pleural effusions. So examples of transudates: heart failure, cirrhosis, chronic kidney disease, nephrotic syndrome, then in hypothyroidism, right? Hypothyroidism, any condition which causes hypoalbuminemia like Crohn's disease. Then also, if you got a ovarian malignancy, ovarian tumor, then you can get right-sided pleural effusion, and that's called Meek syndrome, right? So these are the causes of transudate type of pleural effusions. The transudate type of pleural effusion, right? So you need to remember that. All right. What are the transudates? Heart failure, cirrhosis, nephrotic syndrome, chronic kidney disease, any cause of hypoalbuminemia like in malnutrition or malabsorption syndromes. Then also in hypothyroidism, and last but not the least is in ovarian tumors. Right? Then guys, what are the examples of exudate type of pleural effusions? Exudate type of pleural effusions. So the exudate type of pleural effusions, the commonest cause in the whole world is when you get a pneumonia, along with that pneumonia, you get a pleural effusion, and that we call as sympathetic effusion or parapneumonic effusion. So that is called sympathetic effusion or a parapneumonic effusion. That's the commonest cause. Then you have TB. Tuberculous effusion. It's also exudate, TB effusion. Then you have malignancy, bronchial carcinoma. Bronchial carcinoma can cause a malignant pleural effusion, and there also the protein content is high. Pulmonary infarctions due to thromboembolism, like pulmonary embolism, can cause pulmonary infarctions, and that can cause pleural effusion. And that is also exudate type of pleural effusion. Okay, exudate type of pleural effusions. Then connective tissue diseases like rheumatoid arthritis, SLE, then also acute pancreatitis, that also can cause pleural effusions, which is exudative type. So what are the examples of exudative type of pleural effusion? Parapneumonic effusion, or what you call sympathetic effusion, then tuberculous effusion, connective tissue diseases like SLE and rheumatoid arthritis causing effusions, right? And then pulmonary infarction due to pulmonary embolism that causes a exudate type of pleural effusion, right? And then also lung malignancy, lung cancers, they can cause exudate type of pleural effusions. Guys, among these, 3 effusions are bloodstream, and the other one is mesothelioma. So mesothelioma is following long-term exposure to asbestos. When you are exposed to asbestos sheets over a long time, long period, then you can get lung cancers, lung malignancies, or sometimes malignant pleural effusions following that. So asbestos lung disease, you get a condition called mesothelioma. What is it? Mesothelioma. And the mesothelioma is a malignant pleural effusion. It's a malignant pleural effusion, and that's also exudative pleural effusion. Guys, I gave you 3 examples of I gave you several examples of exudative pleural effusions, but among them I'm going to pick 3 causes. Why? Those 3 causes are not only exudative pleural effusions, but they are also blood-stained pleural effusions. All right. So what are these blood-stained pleural effusions? Number 1, lung malignancy. In lung cancers, you get a blood-stained exudate type of pleural effusion. Then pulmonary embolism. So pulmonary embolism causing pulmonary infarctions, you get blood-stained pleural effusion, right? Then the third one is chronic asbestos exposure causing mesothelioma. So mesothelioma also causes a blood-stained pleural effusion. Remember, conditions like TB, parapneumonic effusions, SLE, rheumatoid arthritis, though they are causing pleural effusion, that is just an exudate only, but there are no red cells. There's no blood in it. But if you got lung cancer causing pleural effusion, lung malignancy, then mesothelioma, and also pulmonary infarction causing pulmonary embolism, if that causes pleural effusion, that is also bloodstream. So there are 3 causes of bloodstream pleural effusion which you need to remember. All right. So I covered a lot of areas about pleural effusion. What are the physical examination findings of pleural effusion? So if I have got water in my lungs, so here when I percuss is resonant, and here is dull, and here it will become stony dull. That is stony dull percussion node. So stony dull percussion node is a hallmark feature of a pleural effusion. So so when you get a pleural effusion, when you percuss the lung, you get a stony dull. It's very important to remember that term, stony dull percussion node. So it's quite a significant percussion node which is very dull, and that is called stony dull, like hit into a stone, So stony dull percussion node over a pleural effusion. What about the lung sounds? What about the air entry over a pleural effusion? Over a pleural effusion, the air entry is markedly diminished. There's no air entry because the lung is collapsed and the entire thing is air. So there's no more air coming into the lungs. So you can't hear any breath sounds. So breath sounds are diminished, or absence of breath sounds. But however, there will be mild airflow, but the air entry or the lung signs, the auscultatory breath sounds will be markedly diminished, okay, over pleural effusion. So the first feature is stony dull percussion note. The second feature is reduced air entry over the pleural effusion. Not only that, guys, can you remember used to keep this ulnar border of the head and ask the patient to say 99, 99, 99, 99, 99. So when you say 99, you can feel a vibration. 99, 99, 99. And here, when you say 99, because over the pleural effusion, you don't hear that you don't feel that vibration to your ulnar border of the head. So the vocal fremitus is diminished or vocal fremitus is absent. Then also, guys, you wear the stethoscope and ask the patient to gently say 99, and you see whether the patient has got increased vocal resonance, and that also happens in happens over a pleural effusion. So the vocal resonance is diminished and the vocal fremitus is diminished. So what did I say? You got a stony dull percussion note, you got reduced air entry, you got reduced vocal fremitus and reduced vocal resonance, or absence of vocal fremitus or absence of vocal resonance, okay, over the area of pleural effusion. So those are the clinical features of a pleural effusion, which all of you should remember. All right. So I have given you the history of pleural effusion. I have given you causes of pleural effusion. I have taught you the pathophysiology, and also I have taught you physical signs of pleural effusion. So how do you diagnose pleural effusion? Is by doing the chest X-ray, and that I have taught you how to identify pleural effusion in the chest X-ray. That increased whiteness. It's a homogeneous white opacity with a meniscus sign, and that is classical pleural effusion. Then also we did some theory on pleural effusions. We have actually covered pleural effusions completely for you, ERPM part A, B, C, all three categories. So when you get a chest X-ray, how do you interpret that? So you will see obliteration of the costophrenic angle, and also there's increased whiteness, which is suggestive of pleural effusion, increased whiteness in the X-ray. Then after that, what will you do? When you have a pleural effusion, how do you treat that? You have to aspirate it, right? You can't just keep fluid in the pleural space. You must aspirate it. So you pop in a needle like this and connect to a three-way catheter and remove pleural fluid. So in the pleural fluid, what do you analyze? You have to see the color of pleural fluid. I told you three conditions you get blood-stained pleural effusion. Now, guys, the students usually make a common mistake. They think tuberculous effusion is blood stain, which is not. In TB, your sputum is blood stain. You get hemoptysis, but pleural effusion is not blood stain. Pleural effusion is not blood stain in tuberculosis. Remember that carefully. What are the blood stain pleural effusion? Lung cancer causing a malignant pleural effusion. Number two, pulmonary infarction due to pulmonary embolism causing exudate type of pleural, exudated bloodstain type of pleural effusion. The third one is due to chronic asbestos exposure. You can get pleural effusion, which is bloodstain, and that is called mesothelioma. Mesothelioma. Right. So you have to look at the color of pleural effusion when you aspirate. Then you have to aspirate and send some samples for pleural fluid full report with cytology, then pleural fluid for glucose, pleural fluid for proteins, and simultaneously you have to check the serum proteins as well. Then you need to check pleural fluid. Yeah, I told about proteins. You have to check the pleural fluid LDH and see whether that is pleural fluid LDH divided by serum LDH, whether it's more than 0.6 or less than 0.6. Okay, so these are the things that we analyze in pleural fluid. Very important. So you can see these are pictures of pleural fluid aspirations. Right. So we have covered two major areas in respiratory medicine. So we know now how to identify a pneumothorax, the treatment, causes, everything I have covered. We also covered a case of pleural effusion, the clinical features, pathophysiology, pharmacological management, X-ray interpretation, all that I have done of a pleural effusion. The causes of pleural effusion, exudate, transudate, all that we have done, right? The pneumonias, the next white shadow, it is also white shadow called pneumonia, or you call it consolidation. The other term is consolidation, right? Now, how to identify a pneumonia or a consolidation? So, just give me a second. Give me a second, please. I'll just take a just 2-minute break. All right, let's start after this 2-minute break, or 1 minute, rather 1 minute break. So pneumonias. So what is a pneumonia? Pneumonia is also called a consolidation. So you know pneumonia is an infection of the lung parenchyma. In our respiratory medicine lectures, the first lecture was on pneumonia, right? So pneumonia can be due to several causes. These days pneumonia is the hottest topic in the whole world due to this COVID-19 infection. So pneumonia can be due to bacterial infections, it can be due to viruses, it can be due to chemical pneumonia like aspiration pneumonia. So there are, it can also be due to fungi, like in immunosuppressed patients you can get fungal pneumonias like that. There are several causes of pneumonia. So in radiological terms, in X-ray, you call the pneumonia as a consolidation, right? So what are the clinical features of pneumonia? What clinical features do you get in a pneumonia? Yes. So the patient usually present with cough, shortness of breath, and when he cough, he will bring out phlegm, infected phlegm. So he will complain, my sputum or my phlegm is yellowish in color. Okay. Now normal pneumonias, your phlegm or the sputum will be yellowish in color because it's infected sputum. Whereas some people, they might say my sputum is blood stain. So in addition to your pneumonia, the productive cough where you bring out yellow colored sputum, you also bring out blood stained sputum. What pneumonia brings out blood stained sputum? Streptococcus pneumonia. Guys, this is a single best answer question I did now. Streptococcus pneumonia can produce blood stained sputum like hemoptysis. Remember that, very important. Then another pneumonia which occurs in the upper part of the lung produces red, very sticky, like jelly-like sputum. So we call it red currant jelly-like sputum. What did I say? Red currant jelly-like sputum. And that occurs in Klebsiella pneumonia. This question was asked in the last ERPM paper, 2018, some paper, I think 2018 May or something like that. So red currant jelly sputum. Red currant jelly sputum occur in a Klebsiella pneumonia. Klebsiella pneumonia. So you need to remember that. Red currant jelly sputum. Then certain pneumonias, they produce green colored sputum. Greenish sputum. What are they? Pseudomonas. When you grow an organism called Pseudomonas, you bring out greenish sputum. All right. So these are types of pneumonia and their respective sputum color. So the patient complains of cough with production of sputum most of the time. But some pneumonias, you don't get that much of sputum. What are the examples? They are the atypical pneumonias. Examples like Mycoplasma pneumonia, Legionella pneumonia, Chlamydia pneumonia. In them, and even your influenza pneumonia, H1N1 infection, what you call swine flu, or H5N1, what you call avian flu, in them. Even this your COVID-19 infection, you don't bring out that much of phlegm. It's almost like a dry cough. So pneumonia patient, they complain of cough. Some people bring out phlegm, you call it productive cough. Some people don't bring out phlegm, then you call it dry cough. When they cough, they also get a pain in the area of the lung which is infected. So if this is the area of my chest lung where I have got the pneumonia, and when I cough, I will get pain over this area. What is that called? Pleuritic chest pain. It's called pleuritic chest pain. So over a pneumonia, if you cough, then your pleura, they rub on each other, is inflamed pleura, and you get pain, and that's called pleuritic chest pain. When you cough, if you get chest pain, that's called pleuritic chest pain. What else do they get? They also get tachycardia. When you get pneumonia, your heart rate is high, your respiratory rate is high, tachypnea, and your saturation, because that one big area of the lung is infected, so the gas exchange is diminished, therefore your oxygenation is low, so you get hypoxia. So hypoxia also become a feature of pneumonia. Then when you get a patient with pneumonia, they also have fever. Majority of patients are having fever. Conditions like streptococcal pneumonia, the fever spikes are very high. Whereas Mycoplasma legionella disease, Mycoplasma pneumonia, Legionnaires disease, or Legionella pneumonia, Chlamydia pneumonia, the fever is not that significant. It's relatively low. So I give you history, clinical features, or the symptoms of pneumonia. What are the physical signs of pneumonia? So when you examine a patient with pneumonia, so if I have got right-sided pneumonia, like in the first X-ray, you can see that area, the infected part of the lung, the expansion is diminished. So if I got right-sided pneumonia, my left lung will expand normally, but the right lung expansion is minimum. So it will go like this. So left lung expansion is very good, but the right lung expansion is minimum. Why? My right lung is infected. So reduce chest wall expansion. Then when you percuss over the area of consolidation or pneumonia, you will get a dull percussion note, right? Dull. It's a dull. Now pleural effusion, stony dull. Here only dull, a dull percussion note over the area of a consolidation or over the area of a pneumonia. What did I say? Dull percussion note. These have been asked in the exam, part ERPM part T, the single best answer paper. So you get a dull percussion note, right, when it comes to percussion. Then guys, when you do the vocal frametus and when you wear a stethoscope and look for the 99 sounds, they will be exaggerated. So you call it increased vocal frametus and increased vocal resonance. So in over a consolidation, you get increased vocal frametus and increased vocal resonance. Okay, right. And next thing is you auscultate with the stethoscope. Now you are going to see here what type of lung sounds, the auscultatory sounds that you hear over a consolidation. So as you put the stethoscope in there, you hear a sound like this. Normal breath sounds are. That's normal breath sounds. But here, so what is that? As if blowing into a tube, and that is called bronchial breathing. Bronchial breathing. So over a consolidation, you can hear a patch of bronchial breathing. Over the consolidation, you will hear bronchial breath sounds. And not only that, there'll be localized crackles whenever you get infection, and when there's inflammatory fluid, you get crepitations or crackles. So, so remember, in over a consolidation, you also can hear crackles or crepitations. So these are the physical signs that you will elicit over consolidation. What are they? Reduced chest wall expansion, dull percussion note, increased vocal frametus and increased vocal resonance, and also they have bronchial breathing. Guys, these are all single best answer questions, you must remember. So all these clinical features I have mentioned here, symptoms and signs of consolidation. So everything beautifully explained in this slide, which you need to remember. All right. So now you know the history, the physical symptoms. Sorry, you know the symptoms, you know the physical signs of a consolidation. Now you need to confirm whatever um, whatever you have heard, the lung signs, and whatever the differential diagnosis that you have made, you have to confirm by doing a chest X-ray. So in a chest X-ray, how will a consolidation or a pneumonia will look like? Now look at this first X-ray film. So in this extreme left corner, in this X-ray, you can see the left lung field is completely normal. The left lung field is completely normal. Whereas the right lung field, you can see right upper zone is okay, right mid zone is normal, but the right lower zone, look at this white shadow. Can you see this? There's a white shadowing in the right lower zone. White shadowing in the right lower zone. So what is that? It's a right lower zone or right lower lobe pneumonia. It's a right lower lobe pneumonia. Guys, these pneumonias we subdivide into two categories. If your pneumonia occurred while you were in the community, and also if you did not have any hospital contact over the last 2 weeks, we call it community acquired pneumonia. What did I say? If you got the pneumonia while you were in the society, while you were in the community, and if you did not have any hospital contact, that means you have not gone to the hospital to see a patient, or you were not hospitalized before. So if you did not have any hospital contact over the last 14 days, right, you should not have that. Then you call it a community acquired pneumonia. Whereas if the patient develops pneumonia after 48 hours of admission to the ward, how much? After 48 hours of admission to the ward, that means after 2 days of admission to the ward, if you get uh, pneumonia, then you call it hospital acquired pneumonia. That's called hospital acquired pneumonia. So now you know community acquired pneumonia versus hospital acquired pneumonia. So community acquired pneumonia in the whole world, what is the commonest cause? Streptococcus pneumoniae. Commonest cause is Streptococcus pneumoniae. Then you have the next common organism like mycoplasma, viruses, then Legionnaires, chlamydia, aspiration pneumonia, there is chemical pneumonitis, things like that. Okay. Right. So guys, even the pneumonia will be shown as it's a whitish shadow, white colored shadow, right? White colored shadow. So this is a case of right lower zone or right lower lobe community acquired pneumonia consolidation. Then there's a classical hallmark sign in radiology that we give for a patient with consolidation. So when you get a consolidation in the chest X-ray, you must look for what is called AR bronchogram. What is AR bronchogram? AR bronchogram, you can see our windpipe, they divide into various branches, isn't it? Our trachea, main bronchus, terminal bronchioles, they divide into various sub-branches. So when air goes through these sub-branches, you can see black colored lines. Now look at this, follow this. Can you see these black shadows here? Black shadows, either rounded or tubular. Now can you see, I don't know whether you can see it in the middle film, but in this CT scan, obviously you can see. Can you see these black colored lines? Here, black colored lines over the consolidation. And these are what you call AR bronchogram. The black colored lines that you see uh, inside these whitish shadows is called AR bronchogram. So the classical radiological finding in a patient with consolidation or pneumonia is so whitish shadow, or whitish shadows we call it opacity. Opacity with AR bronchogram. It's an opacity with AR bronchogram. Right? So with the consolidation with AR bronchogram, the consolidation appears as opacity. Opacity, there's the white shadow, opacity with AR bronchogram. So that is how you recognize a pneumonia or consolidation in a chest X-ray. How do you treat pneumonias? So you take blood culture and also preferably a sputum culture, and then you give antibiotics for this patient. But there's a way to do that. So how do you treat community acquired pneumonia? First of all, because it's a medical emergency, so you have to assess airway, breathing, and circulation of this patient, ABC. So you go through ABC of this patient and see whether the patient is hypoxic. If the patient is hypoxic, you need to give them oxygen, either via face mask or nasal cannula. You have to give oxygen, right? Very important. Then also, guys, if you suspect a pneumonia in a patient, you have to take sputum for culture, blood for culture, and then start on uh, broad spectrum IV antibiotics, broad spectrum IV antibiotics. That is as the treatment of pneumonia, because antibiotics are the mainstay or the cornerstones of therapy of pneumonia. So after taking blood culture and sputum culture, without any delay, you have to start on IV broad spectrum antibiotics. So the good antibiotics for a severe community acquired pneumonia are like drugs like IV ceftriaxone or IV cefotaxime, or even drugs like IV amoxicillin clavulanic acid, or what you call coamoxiclav. So guys, we discuss about pneumonia. So it's an opacity with air bronchogram. The causes of pneumonia we have discussed. Clinical features of pneumonia we have discussed. All right. So how do you treat pneumonia? That also I have done with you now. How to take sputum culture, blood culture, then what antibiotics we give, all that we have done. Sorry. So pneumonia, this is the algorithm, how you treat pneumonia. So this is community acquired pneumonia, diagnosis is made, and you have to see whether the patient got a lot of comorbidities. If none of those things are there, you just treat as pneumonia. But if the patient has got multiple past medical histories or comorbidities, then you have to assess the treatment as benefit versus disadvantages. Right. So that chart also gives you the preferred antibiotics in various conditions of pneumonia. Right. So this X-ray also shows a classical case of consolidation pneumonia. You can see here the right upper zone. There's loss. Right upper zone. You can see this opacity with tiny black colored shadows. What you call air bronchogram. Air broncho. So right upper zone you can see a shadow or opacity with air bronchogram. So yeah, that's how pneumonias or consolidations appear in chest X-ray. Right. How do you assess pneumonia? So for the assessment of pneumonia, we have what are called pneumonia assessment scores. So we use the something called modified curve 65. Then in the one of the latest ones are something called smart cop. Okay? Smart cop. That's a mnemonic. Like I mean, those are like curve 65. There's something called smart cop that gives you some values to identify the severity in community acquired pneumonia. Because if it is a severe community acquired pneumonia, he might need high dependence unit treatment. If it is a mild to moderate degree, you can manage in the ward with intravenous antibiotics. Right. So when it comes to antibiotics and pneumonia, what are the best antibiotics? Like if it is moderate to severe community acquired pneumonia, one of the best antibiotics are IV ceftriaxone. So in moderate to severe um, uh, community acquired pneumonia, the best first guess or first line therapy is intravenous either ceftriaxone or cefotaxime. But that per se is not enough. Why? You also got atypical organisms like Mycoplasma, Legionella, Chlamydia. So to cover the atypical organisms, you also have to cover them with macrolide or doxycycline. Either macrolide. So what are the macrolides available? Erythromycin, azithromycin, and also clarithromycin. So one of the um, um, one of those antibiotics should be given. So like we go for combination of either ceftriaxone plus clarithromycin, or we go for coamoxiclav, that is amoxicillin plus clavulanic acid. Coamoxiclav 1.2 grams 8 doubly. So coamoxiclav plus uh, coamoxiclav plus clarithromycin. That combination also could be given. So what are the antibiotics regimes? These they have asked in the exam, single best answer paper, in the ERPM as well as in the final MBBS paper. So the treatment of pneumonia, if it is mild to moderate, very mild community acquired pneumonia can be even treated as outpatients. Very mild community acquired pneumonia you can treat even as outpatient with oral medications. But if it is moderate community acquired pneumonia, you must admit to the ward. Even the severe ones, you admit to the ward first. You assess the pneumonia, you assess the saturation, you do arterial blood gas, and then you, after taking sputum culture and blood culture, you start them on IV best gas antibiotics. So what are the best gas antibiotics again? Yes, either you can go for combination of IV ceftriaxone and clarithromycin, or you can go for combination of amoxicillin clavulanic acid, that is IV coamoxiclav, plus a macrolide or a doxycycline. Okay, so any of those combinations are accepted with the treatment of pneumonia. And also remember, any case of pneumonia, when you are treating that, you also have to calculate the pneumonia severity scores. All right. Right. So physical signs in various lung disorders, I have tried to upload in this slide. You need to leisurely go through this. So what is vesicular? What are the conditions which produce vesicular sounds? Then bronchial. Yeah. What are the conditions which produces yeah, what is it? Sorry. What are the condition which produces bronchial breath sounds, bronchiovesicular sounds, fine crepitations, coarse crepitations, wheezes, bronchi, all that I have listed out there. Right. The next respiratory condition that we are going to discuss is a rounded opacity. Rounded opacity with the air fluid interface or air fluid level. And that is called an abscess, lung abscess. So lung abscess, what is the radiological hallmark? I told you, it's a lesion with the air fluid level. It's a cavitated lesion with air fluid level. All right. So you can see here, this is a patient with lung abscess formation, and this you can see air on top and fluid at the bottom. So it's a air fluid level. So air fluid level. That's characteristic of lung abscess. So lung abscess appears a rounded lesion, but in that you see this air fluid level. So air on top, fluid at the bottom, air fluid level. Here you can see a beautiful abscess in the right upper zone. So probably this must be a patient with tuberculosis. You can see the right upper zone. There's a rounded opacity with air on top, fluid the bottom half. So air fluid level or air fluid interface. So this is another patient with lung abscess formation. You can see air and the fluid, air fluid level. So this is what I meant earlier. So this is the lung abscess. You can see air fluid level. Right. So that's how you recognize a lung abscess. Who are the people, those who are more prone to get lung abscess formation? Remember, lung abscesses, you usually get following anaerobic metabolism. Anaerobic metabolism only will produce a lung abscess formation. And in lung abscesses, usually you can produce gas, and that filled up in a that get filled up in an abscess, and that's why you get this air on top, gas, air fluid level. So anaerobic organisms, they play a role in the abscess formation as well as gram negatives. So what are the clinical features of lung abscess formation? So the patient will have very high fever spikes, lethargy, loss of appetite, lethargic, and also very high fever spikes. They will get very high swinging fever spikes, very high fever spikes in lung abscess formation. The patient will be quite unwell, and his respiratory rate is high, pulse rate is high, all those features will be there. So all what I told you before has been mentioned here. So clinical features, they present with high fever spikes, chills and rigors. And what are their physical signs? Physical signs would be again, sorry, not physical signs, symptoms. So patient present with very high fever spikes with chills and rigors. They also complain of cough with hemoptysis, right? So remember, lung abscess is one condition which produces a lot of phlegm. So it has uh, uh, increased sputum production. And in lung abscess formation, you have sometimes very foul smelly and also foul smelly and also very brownish type of uh, sputum in lung abscess formation. And we believe that's due to these anaerobes, right? So remember, lung abscesses, they can get high fever spikes, chills. So they come like this, shivering. So lung abscess formation, they come with very high fever spikes with chills and rigors. That's the first. They also have loss of appetite. They also have lethargy. Then if you analyze their cough, if you ask them for the cough, they complain of cough with one thing brownish or yellowish sputum as well as blood-stained sputum. So what do you call that? Hemoptysis. So remember guys, lung abscess formation can produce hemoptysis, right? So I have mentioned the halitosis. What is halitosis? A bad smell in their breath. So when they breathe in and out through their mouth, you can get a bad smell. That is called halitosis. They also can get purulent, yellowish or brownish khaki colored sputum. Right. Okay. And also when they cough, they will get a pain in the adjacent area. That's called pleuritic chest pain. So what are the physical signs? Again, dull percussion note. Sometimes if it is a big abscess over that area, you might be able to hear some bronchial breathing. But the most important thing is doing a chest x-ray and a CT scan. What investigations will you carry out? So you have to do a blood culture. Um, uh, and in blood culture, you must look for this neutrophil leukocytosis. And also, so blood culture will be there. Blood culture, because you might be able to identify some organism. There will be neutrophil leukocytosis. There will be raised inflammatory markers like very high CRP and ESR. So those will be some of the investigation abnormalities. Then also, guys, you have to do an X-ray. X-ray, what are we looking for? A rounded opacity with the air fluid level. You also have to do a CT scan. Even in the CT scan, you can see this rounded shadow with air fluid level. Right. So how do you treat lung abscesses? Again, with broad spectrum antibiotics for a minimum of 2 weeks. Minimum of 2 weeks. So what are these IV antibiotic combinations? So as I told you before, you can go for different combinations. So you can go for something like IV coamoxiclam or IV ceftriaxone combined with IV, either metronidazole. You must combine because in abscess formation there is anaerobic organisms. Abscesses are caused by anaerobic organisms. So anaerobes, they'll be killed if you add metronidazole. So metronidazole always be added whenever we suspect an abscess formation. So here you can give IV coamoxiclam or IV ceftriaxone combined with your oral, combined with IV metronidazole. Sometimes you also can give IV clindamycin, but the best IV antibiotic combination would be either IV coamoxiclam or IV ceftriaxone combined with flagyl. That is metronidazole. Flagyl is metronidazole. Right. The next topics are bronchiectasis. Then we have lung carcinoma, pulmonary edema. I will discuss on heart failure and also abdominal x-rays. Guys, I plan to do all these things, but I think today it was a very heavy day. Like we had so much of work and I'm on call as well, so a bit drowsy and sleepy. So therefore, like unfortunately, I will have to stop at this stage. after 1 hour and 40 minutes lecture because I'm a bit tired today. Too much of work. Sorry. Um, so guys, so I'll summarize what we discussed all this time. So what did we discuss all this time? We discussed how to make, how to interpret chest X-rays. We have discussed what is called a normal chest X-ray, how to look at the lung fields, how to look at the mediastinum, how to look at the cardiac ratio versus thoracic ratio, whether it's less than 0.5 or more than 0.5, how to look at the body fields, how to look at the diaphragms, gas under diaphragm, all that. So normal chest X-ray, you know. Then I have been taught to discuss a condition called pneumothorax. So not only I showed you the radiological diagnosis of pneumothorax, I also taught you how to recognize clinically the clinical features of pneumothorax, how they present with acute shortness of breath, tachycardia, tachypnea, low blood pressure. Then also I taught you the physical signs of pneumothorax, hyperresonant percussion note, and their air entry will be diminished because nothing to come in. It's already filled with air. So air entry is diminished and the breath sounds are diminished as well. But you get a hyper-resonant percussion note, right? And the treatment of pneumothorax and how to identify that in chest X-ray, I taught you increased black shadows and the lung markings will be collapsed. Then I taught you how to do the needle thoracostomy and then how to connect to a IC tube, intercostal tube drainage with underwater seal. Then we went on to discuss whitish shadows like obliteration of the costophrenic angle causing a pleural effusion. So when you get a pleural effusion, you have to decide whether it's an exudate type or a transudate type. So for that, we apply what is called Light's criteria. And for that, you have to take some fluid out of the thoracic cage, right? To do you have to get fluid out of the thoracic, the pleural space. So that is called pleural aspiration. So when you do the pleural aspiration, if you look at the pleural fluid protein divided by serum protein or pleural fluid albumin divided by serum albumin, then you can do the pleural fluid LDH divided by serum LDH, or you can just uh, uh, look for serum protein more than 30 grams per liter or serum LDH more than 200 milligrams per deciliter. All those features favor exudate. If they are less than those cutoff values, you call it transudate. Then also when you aspirate pleural fluid, you must see the color of it, particularly with this blood stain. Blood stain pleural effusions are malignancy. Then you have pulmonary embolism, and also you have uh, uh, lung carcinoma. So lung carcinoma, mesothelioma, and also pulmonary embolism causing pulmonary infarctions. Those are the three conditions where you can get blood stain pleural effusions, right? Lung carcinoma, mesothelioma, and also pulmonary embolism causing pulmonary infarctions and causing effusions. Those are blood stain effusions. TB effusion is not blood stain, that you need to remember. TB effusions are not blood stain, right? How do they appear and what are the physical signs of pleural effusion? Stony dull percussion note, diminished air entry over that area, and and on the surface of the pleural effusion, you might hear a whispering breath sound that is called whispering pectoralici. Right. So those are physical signs of pleural effusion. What are the radiological signs? So it's a whitish shadow which is blocking the or obliterating the costophrenic angle. And also at the upper margin of the pleural effusion, you get this meniscus sign. So this is how you aspirate the pleural effusion and you go for the needle um, needle aspiration of the fluid, and this is how you differentiate exudate, transudate versus exudate, and the causes of transudate, causes of exudate I have given you. Then we went on to discuss the last topic, that is consolidation or pneumonia following an infection. So it can be bacteria, viruses, fungi, chemical, any type of pneumonia. So the radiological hallmark is called consolidation. What do you notice? So in the chest X-ray, in the lung fields, in the lung fields, you will notice an opacity. You will notice an opacity with air bronchogram. These are called air bronchogram. That is where your terminal bronchioles take air, and that will be shown as black colored lines. So that is consolidation with air bronchogram. So this is also consolidation with air bronchogram. So clinical features, symptoms and physical signs of bronchial breathing, causes of bronchial breathing, and also causes of pneumonia, causes, the causes, how you divide as community acquired pneumonia, hospital acquired pneumonia, that I have taught you as well. And the treatment, how it differs in community acquired pneumonia, hospital acquired pneumonia, I told you. In community acquired pneumonia, what are the best antibiotic combinations? Either IV ceftriaxone plus clarithromycin or IV coamociclovir plus clarithromycin. Why? You have to cover the atypical organisms like Mycoplasma, Legionella, and also chlamydia. That's why you are covering with a macrolide like erythromycin, azithromycin, or clarithromycin. So how do you treat pneumonia? You take sputum culture, you take blood culture, and then give this broad spectrum intravenous antibiotics. It's another picture of pneumonia, right episode, community acquired pneumonia. Right. Then the last topic that we discussed was lung abscesses. So lung abscess appear as a round, it's a mass lesion, rounded opacity. So it's a rounded lesion with air on top and fluid, which is horizontal, is at bottom. So that's called air fluid interspace or air fluid level in a lung abscess. So you can see that beautifully here. You can see this rounded opacity with air on top and fluid at the bottom. So that's called air fluid level in lung abscesses. So it appears in the X-ray as a rounded opacity with this air fluid level. Right. Okay, yeah. So that's lung abscess. Then what are the clinical features of lung abscess? So you patient present with very high fever spikes with chills and rigors, is acutely unwell, he got severe, terrible productive cough, he's trying to bring out phlegm, it's not coming out, and also when he brings out phlegm, it will be a brown or khaki colored sputum which is blood stained. So remember, lung abscesses can produce hemoptysis. What is the pneumonia which produces hemoptysis? Streptococcus pneumoniae. So lung abscess also you can get hemoptysis, brown colored sputum, and also hemoptysis, and sometimes a bad smell in their breath, what you call halitosis. They also can get a pain on coughing in the chest called pleuritic chest pain. Physical signs I have mentioned, dull percussion note and bronchial breathing, and the investigation is nothing other than chest X-ray. That's the first thing, and then you follow that by doing a CT scan. Right. So what is the antibiotic coverage? What is the antibiotic coverage for suspected lung abscess formation? Yeah, what is the antibiotic coverage? So it's either IV coamociclovir plus intravenous flagyl, that is metronidazole, or IV ceftriaxone plus IV metronidazole. Because remember, like whenever you have lung abscesses, it's mainly due to anaerobic organisms. Right? So when you get a lung abscess, mainly is due to anaerobic organisms, and that's why they produce air, and air goes on top. So you have to cover in your antibiotic regime, you have to cover those anaerobic organisms also, and that's why you put them on IV metronidazole. All right. Okay. So that's the place where we stop. I have gone through interpretation of normal chest X-ray, which all of you know how to interpret a normal chest X-ray, which I finished in my last class. How to start to interpret normal chest X-ray, starting from the apex of the lung, going through the periphery to the costophrenic angle, coming along the diaphragm, then to the hilar border of the lung, then going through the zones, upper zone, mid zone, lower zone. You have to see whether there's increased black color like in a pneumothorax, or whether there are any white shadows like what you call opacities or pleural effusions, or opacities like consolidations, mass lesions like tumors, or whether there are any effusions, which I have taught you. I'll just go through them very briefly. Then also, that is the right lung. Then the left lung also, you start at the apex, go through the periphery, go to the costophrenic angle, come along the diaphragm, and come along this hilar border and go to the top. So look at the left apex, that is left upper zone, left mid zone, and left lower zone. So what you have to see is whether there are increased black color shadows, increased white color shadows. So black air is always black color, and the fluid or masses or bones, they are white color. Air is black, and fluids, tumors, this mass lesion or a bone, they are white in color. Keep that in mind, very important in interpretation of chest X-ray. So then after that, you have to look at this mediastinum. Mediastinum, the most important structure is heart. You have to see what the ratio is, this cardiothoracic ratio, that is you take the cardiac diameter and then you divide the thoracic diameter. It should be less than 0.5. If it is more than 0.5, that's called cardiomegaly or enlarged heart. Right? Cardiac diameter divided by thoracic diameter. It should be less than 0.5 in a normal person. If it is more than 0.5, that is cardiomegaly. Then you have to look at this pulmonary trunk on either side. These are pulmonary arteries. And here you have the aortic knuckle. You look at the trachea and how it's divided into two main branches, bronchi, that you need to see. And also sometimes here you can see lymph nodes, hilar lymph nodes, like in tuberculosis, sarcoidosis, and also lymphoma. You can get this lymph node enlargement. Then you have to look at these bone shadows. These are the ribs. Then you have the, these are the ribs. These are posterior ribs. These are posterior ribs. These are posterior ribs. And these are the anterior ribs, which are going in an oblique manner. These are the anterior ribs. Right? These are anterior ribs going down like this. So usually there are less than 7 anterior ribs above the diaphragm. If it is more than 7 ribs anteriorly above the diaphragm, that is COPD, air trapping. Then also in these ribs, you have to see if there are any fractures, whether there are black colored holes, what you call as lytic lesions, which you get in multiple myeloma and also metastatic deposits in cancers, you can get them. You also have to look at the clavicles, whether there are any fractures or any metastatic deposits. You also need to look at the scapulae, then the soft tissues here at the root of the neck. Here you can see a retrosternal goiter if you have got a large goiter, retrosternal goiter. Then you have to look at the lateral chest wall, whether there is any air here like subcutaneous emphysema. You have to look at the breast shadows. Then finally you have to look at this diaphragm. Usually the right diaphragm is above the left diaphragm. This is little up due to the liver. And usually there's no gas under the diaphragm. If there's gas under the diaphragm, that suggests that there's perforated viscous, like ruptured appendix, ruptured bubble loop, something like that. All right. Then also, you need to, so these are diaphragm. Then on the right side, so you have to follow this claustrophrenic angle. That should be very clear. It should be black color. This claustrophrenic angle is obliterated, like if there's any white color filling here, that is pleural effusion. Here, this is the left claustrophrenic angle. It has to be very clear like this, black color. If there's white color, obliteration, there's white color opacity, and if there's any obliteration of this claustrophrenic angle, that is called pleural effusion on the left side. Then this is the left hemidiaphragm. Here you can see the gastric air bubble, which is normal finding. So this is how you interpret a chest X-ray. So you have to go through so many normal chest X-rays. First of all, try to interpret the way I told you. So whenever you go to see a patient, whenever you see a chest X-ray, you hold it and you try to interpret the way I have taught you. That is the proper interpretation of chest X-ray. It's a very important thing for any doctor to understand how to interpret a normal chest X-ray, because you have to first identify what is normal before you identify what is abnormal. So this is again interpretation of normal chest X-ray, as you can see in this slide. Then we went on to discuss abnormal chest X-rays last class. I taught you what is called pneumothorax. So what is pneumothorax? That is in the pleural space. In the pleural space, you get collection of air. So this pneumothorax can occur. So I'm going through these areas a little faster because I have taught these things already in the last class. So just for the new ones, those who are joining today, I'm doing it with, I'm just going through what I did last class for them to also to get some information about it. But I had done this already. So pneumothorax means air in the pleural space. During a normal person, you have your lungs. Lungs are covered by visceral pleura. The thoracic case, you have the parietal pleura. Between the parietal pleura and visceral pleura, there's some thin rim of fluid. That's normal finding. But if you get gases between the parietal pleura and visceral pleura, that means pleural space, if you get gas, air, that is called pneumothorax. So what did I teach you earlier? Air is always shown up in black color. So this is all black color. Can you see this? This is black color air. So this is a pneumothorax. Can you see this? So this is the peripheral thoracic cage. This is the diaphragm. Here you can see the lung marking. Can all of you all see this lung marking here? So this is the lung tissue. This is the lung tissue. Lung is collapsed. Here, lung is collapsed. Lung has come against the mediastinum. It's a collapsed lung. And rest of the lung, rest of the thoracic cage is all filled with air. Here, you can't see any vascular markings. But compare this left lung. Left lung, can you see that there are white streaks of vascular markings? Inside the vessels, you have blood. So blood is always white color. That's why you see white streaks going to the periphery. So this is a normal lung here where you can see white streaks of blood vessels going to the periphery. But here white streaks are only up to this line. So this is the lung, and rest of the field is all air, black colored. So black colored air is called pneumothorax. How do you get pneumothorax? It's a medical emergency. Number one, trauma. Like if you have a stab injury, road traffic accident, blast injuries, crush injuries, you gas, because you can get rib fractures. Once the ribs are fractured, you can have gas leaking into your pleural space. That's the that's traumatic pneumothorax. Then you also get pneumothorax in various medical conditions. COPD, bronchial asthma. You can get ruptured bulla, and there, due to ruptured bulla, air can leak into the pleural space, and you can get pneumothorax. Then also there are certain connective tissue diseases like systemic sclerosis, Marfan syndrome. In those you can get spontaneous pneumothorax. All of a sudden, there can be ruptured air spaces and air leaking into the pleural space. Then also that day I taught you, there's a condition which is mentioned in Oriental, that is like Chinese, Japanese, Asian, thin, tall men, where they can end up with pneumothorax. So these are some conditions where you can get pneumothorax. What are the clinical features of pneumothorax? You get sudden onset, severe shortness of breath. Sudden, very acute onset, severe shortness of breath. Not only that, their respiratory rate is high, tachypnea, tachycardia, heart rate is high. Blood pressure drops. So when there's a lot of pressure around the heart contractility reduces. So your blood pressure drops. And patient is in severe distress. Right? So those are clinical features of pneumothorax. So when you have a patient with severe pneumothorax, and sometimes if you get a severe pneumothorax, you can get, or what you call tension pneumothorax, the trachea will be shifted to the opposite side. And when you get a pneumothorax, it's a clinical diagnosis. You are not waiting to confirm that by X-ray, because every second costs patient's life. So what you need to do is you take a large bore needle, like a blood needle. You can take a 14 gauge or a 15 gauge needle, and you just prick that side of the pneumothorax through the upper second intercostal space laterally, like this. Upper second intercostal space laterally. You just take a needle and prick into that pleural space, and then you can hear the sound zzz, like that, air goes out. You also can connect a tube to that needle and drain that air under water seal. You can take a kidney tray filled with water, and you can see air bubbling through there, and patient's tension is relieved, and patient is completely back to normal. Then you have relieved the acute tension. Then you take a chest X-ray and confirm this X-ray finding of pneumothorax. Then you call your surgical colleagues, and you go for the definitive management, which is insertion of a intercostal tube, IC tube. So IC tube will be put in here. This is also another pneumothorax, and this is another pneumothorax on your left side, this one. So this is a left-sided pneumothorax here. So IC tube will be put into this pleural space, and that air will be drained out. And when you drain out air through this IC tube, so patient is like this, tube is coming out. So if this side is pneumothorax, so tube is coming out, and that water seal, the bottle, should be kept below patient's level. And you should never ever clamp a IC tube. It's a take-home message. Please remember this golden advice for your whole life. You must always tell the nurses, never clamp IC tube. Even if the patient is going to the toilet, the patient should carry the bottle, water seal bottle, and go to the toilet and come back. But you should not put a clamp on the IC tube. That's 100% wrong. So you can see here. So this is this is the place where you go with the IC tube insertion, and also where you go for needle thoracostomy. So when you pop in a needle, to your pleural space, you call it needle thoracostomy. Needle thoracostomy, right? You can see this is how you pop in a needle and drain that air. That's called needle thoracostomy, which all these things I taught in the last class. So you can see here, this is how you insert IC tube from a pneumothorax, and you drain that air into this bottle, which is underwater seal. And there are two tubes in this bottle. Can you see? There are two tubes. One tube is going to the pleural space. It is draining this air, which is under pressure, and it will bubble through this water. Bubble through this water. And the other smaller tube connects to the air. So that makes the pressure inside this bottle makes it atmospheric pressure. So because this tube will make the atmospheric pressure created inside this bottle. So that due to that pressure difference, there will be continuous bubbling of air through this. So as a house officer, when you become a doctor, you have to see whether this IC tube is draining air, and if it is bubbling, you know it's working well. And also there's a fluid level which swings every day with breathing in and out. You can see here, this is a true IC tube. You can see it's inserted to the patient, and this is the tubing, and this is the underwater seal, the bottle. You can see the tube is going into this bottle, and it's always kept below the patient's body level. So this is another IC tube inserted to the patient. All right. So that is treatment of pneumothorax. And once you insert IC tube, you also have to take a chest X-ray to confirm that it is in the right position. Okay, all this I taught you, so that's why I'm going a little faster in these areas. So just bear with me, the new students, those who joined today, because I have taught this already. Okay, actually, as a benefit of you all only, I'm teaching this again, otherwise I don't have to do this. So this is so that is black color shadows. Now we are going to talk about white color shadows. When you take white color shadows, the most important thing is, so in this pleural space you can get water. So when you get water in the pleural space, you call it pleural effusion. Pleural effusion. Water in the pleural space is called pleural effusion. Blood in the pleural space is called pneumothorax. Pus, infected material, pus in the pleural space is called empyema. Then cholesterol-rich fluid in the what you call chyle. That is, if that is there in the pleural space, that's called chylothorax. So these are different types of various fluid collections in your pleural space. So pleural effusion, you can see here, you can see as a white opacity. And also guys, remember, if you get a pleural effusion, it is white color opacity and it's a uniform opacity. That opacity you can nicely see. And also you can see that white opacity is rising upwards. Can you see? It's rising upwards. It's blocking the, earlier I taught you that costophrenic angle. What is costo? Costo means ribs. Sorry, costo means, yeah, the rib cage, and phrenic means the diaphragm. So costophrenic angle. Here you can see on the right side, costophrenic angle is nice and clear. But on the left side, what has happened? The costophrenic angle is obliterated and it has become white. So there's fluid here, that's why it has become white. And also you can see this line is raising up. So that is called meniscus sign. Meniscus sign, like a meniscus. So that is a feature of pleural effusion. You can see another pleural effusion with a meniscus sign here. And you can see another pleural effusion here on the right side of the chest. And here you can see the nice white color fluid. And here you can see the meniscus sign. Meniscus sign. Here is another pleural effusion on the left side of the chest with a meniscus sign going up. So remember, pleural effusion, the smallest pleural effusion will only have obliteration of costophrenic angle. It's a white color opacity. It's a uniform white color opacity. Uniform. Everywhere it's white. It's a uniform white color opacity, and first at the beginning it will just block the costophrenic angle and you will get this meniscus sign. So remember these features in a pleural effusion. So what are the causes of pleural effusion? Pleural effusions can be divided because you when you take some pleural fluid for analysis, you apply what is called Light's criteria. You check the pleural fluid albumin or protein, pleural fluid LDH, and that you compare with the serum albumin or serum protein or serum LDH. And then with that ratio, you can decide whether it's an exudate or transudate. This I taught you in the last class. So what is an exudate? Pleural fluid albumin or protein, pleural fluid albumin or protein divided by serum protein or serum albumin or serum protein. It should be in a normal person less than 0.5. If your pleural fluid albumin or pleural fluid protein divided by serum albumin or serum protein. If it is more than 0.6, yeah, I can show you that. If it is more than 0.5, that's called an exudate. If it is more than 0.5, you call it an exudate. In a transudate, pleural fluid protein divided by serum protein is less than 0.5. That's transudate. Then also in an exudate, LDH ratio, pleural LDH divided by serum LDH is more than 0.6 in the exudate. Pleural LDH divided by serum LDH is more than 0.6. It is less than 0.6, you call it a transudate. Also, you can take the gross value, like in a normal person or in a transudate, pleural fluid protein is less than 30 grams per liter. In exudate, more than 30 grams per liter. Pleural LDH in a normal person or in transudate, less than 200. In exudate is more than 200. Exudate LDH level is more than 200. All right, right. So, so this is how you identify a pleural effusion. What are the causes of pleural effusion? So in order to understand what are the causes of pleural, so here I have given you list of causes of exudates, list of causes of transudates. First we will discuss list of causes of exudates, where the proteins are high, LDH is high. Proteins more than 0.5, LDH more than 0.6 from the serum values. So exudate number one cause is parapneumonic effusion. That is, you get a pneumonia and following that you get some fluid collected in that side of the lung. That is called parapneumonic or sympathetic effusion. Sympathetic effusion or a parapneumonic effusion. That's number one. Number two, in our country, this is common. And also in the South Asian countries, Russia, it's common. What is that? Tuberculous effusion. Also exudate. Tuberculous effusion, TB effusion. Number three, a malignancy, lung cancer, causing pleural effusion. It's a malignant pleural effusion. Number four, pulmonary embolism, causing pulmonary infarction, causing a pleural effusion. Number five, mesothelioma, causing pleural effusion. That is following long-term exposure to asbestos that can cause a condition called mesothelioma, blood-stained pleural effusion. Guys, pay your attention. Number five, number four, number three that I told you. Can you recall what is number 3, 4, 5? 3 is lung cancer, lung malignancy causing a malignant pleural effusion. Number 4, what is it? Pulmonary infarction due to pulmonary embolism causing pleural effusion. Number 5, mesothelioma due to long-term asbestos exposure. These three conditions are blood-stained pleural effusions. What is the color? Blood-stained. But number 1, number 2, that is parapneumonic effusion. TB effusion is not blood-stained. Though in pulmonary TB you cough out blood-stained sputum or what you call hemoptysis, their pleural effusion is not blood-stained. Remember that. Very important MCQ. Then next thing is the other rest of the exudates are like, you know, when you get SLE, when you get rheumatoid arthritis, also you can get an exudate. When you get acute pancreatitis, also you can get a exudate. That also you need to keep in mind. Then what are the examples of transudates where the proteins are low, your LDH is low? So examples of transudates are most of the time bilateral. Both sides you get that, transudates. What are the examples? Heart failure, congestive cardiac failure. Number 2, cirrhosis. Cirrhosis, you get pleural effusions. Nephrotic syndrome, you get pleural effusions. Kidney failure, chronic renal failure, you get pleural effusions. Then hypothyroidism, you get pleural effusions. Then also ovarian tumors can cause right-sided pleural effusion, and that's called Meek syndrome. So these are causes of exudates, transudates. Big topic I covered now. It's not just showing x-rays. It's teaching you a lot of theory, right, of respiratory medicine. All right. And whenever you have a pleural effusion, first you confirm by a chest x-ray. But before chest x-ray, what do? How do you clinically suspect? There should be physical signs to suspect a pleural effusion. So what are the physical signs that suggest a patient is having a pleural effusion? Number 1, the chest wall expansion is reduced. So reduce chest wall expansion on that side. Number 2, you percuss the chest. So normal percussion note is resonant, but when you percuss over a pleural effusion, which is usually low down, you get a stony dull percussion note. What is it? Stony dull, like hitting over a stone. stony dull percussion note over a pleural effusion. Remember that it's MCQ, single best answer question. Then third point, you know that 99, when you keep your hand and say, ask the patient to say 99, 99, you can feel the vibration, or you ask the patient to, you wear the stethoscope and ask the patient to say 99 and you hear with the stethoscope. That is called vocal resonance. So that vocal fremitus and vocal resonance is diminished or absent over pleural effusion. Your air entry, your breath sounds that you auscultate, that is also diminished or absent over pleural effusion. So remember those features. This is another single best answer question I covered. The clinical features of pleural effusion: reduced chest wall expansion, stony dull percussion note, reduced or absent air entry, reduced or absent vocal fremitus and vocal resonance. All right. So these features will be there in a pleural effusion. Right. So then when you have that suspiciousness, you do a chest X-ray and you will see the opacity that I showed you earlier, a classical pleural effusion. Then after that, what you need to do is you have to take out this fluid. You can see here, the patient is sitting like this and you pop in a needle and you drain some fluid. Right. So that is, you do a pleural tap. It's called pleural tap. You tap the fluid, take it out. So that's called the pleural aspiration, right? Needle aspiration. So this is how you do the needle aspiration. You pop in a needle like with a cannula, and then you connect this three-way tap and you drain fluid. You pull this syringe and drain it out. This is another ultrasound guided pleural aspiration here. So why do you have to aspirate this fluid? One thing is it relieves your symptoms, and also for you to analyze whether it's exudate, transudate. Not only that, if you are suspecting a TB effusion, tuberculous effusion, you can do adenosine deaminases in that fluid. What did I say? ADA. So ADA is strongly positive in TB effusions. You can analyze the cells in this pleural effusion and see whether there are malignant cells. So cytology is important. If you have a lot of pus in it, a lot of bacteria in it, you call it a complicated effusion. There will be pus cells, there will be a lot of organisms, there will be low glucose as well. Those you can learn in our theory classes. So I taught you a lot of theory as well. Right. So that is pleural effusion. Then comes pneumonia, or what you call consolidation, pneumonia or consolidation. Now guys, what is pneumonia? Pneumonia is an infection of the lung parenchyma. Pneumonia is infection of the lung parenchyma. So usually, so this pneumonia is a very hot topic because you can get viral pneumonias like these hantavirus infections, H1N1, influenza, like that is swine flu. You can get H5N1 or bird flu, or what you call avian flu. These days, COVID-19 infection is there. Corona infections causing so many deaths in the world. So those are viral causes of pneumonia. Cytomegalovirus is another cause of pneumonia. But there's quite a lot of causes of bacterial pneumonia. Among the whole world, in the whole world, among all the causes of pneumonia, what is the commonest cause? The commonest cause of pneumonia is Streptococcus pneumoniae. Streptococcus pneumoniae. Then you have the atypical organisms, that is Mycoplasma, Legionella, and also Chlamydia. Mycoplasma, Legionella, and Chlamydia. But the commonest cause in the whole world is Streptococcus pneumonia among the bacterial causes. So when you get pneumonia, what are the clinical features? In pneumonia, what are the clinical features? Patient gets high fever. Patient gets fever because bacteria has gone into your lungs. So you get high fever, sometimes with shivering, very high fever. Then also patient get a cough, right? A prominent cough. Some pneumonia, you bring out phlegm. So they are called productive cough. You bring out sputum. In certain pneumonias like atypical pneumonia, there is no production of sputum, right? So almost like a dry cough. So for example, Streptococcus pneumonia, you bring out sputum, usually yellowish, infected sputum is Streptococcal pneumonia, yellowish sputum. In Klebsiella pneumonia, you bring out what is called red currant jelly like sputum. It was a fast ERPM single best answer question. Red currant jelly like sputum you bring out in Klebsiella pneumonia. In Haemophilus influenza infection, you can bring out greenish sputum or dark yellow sputum. So that's important. In atypical pneumonias like mycoplasma, legionella, and chlamydia, usually there's not much of sputum production, not much of cough also. So these are differences of various types of pneumonia. So fever, cough, and they have shortness of breath, difficulty in breathing, their respiratory rate is high. Patient is also ill looking, right? When you got a pneumonia, you ill looking because you know pneumonia is a killer. In elderly patients, the commonest cause of killer is pneumonia, very elderly patients. So and these days, you know how many deaths in the whole world due to pneumonia, right? More than 200,000 of deaths these days due to a viral pneumonia. You know that in the statistics. So pneumonia is a deadly disease. So they are acutely unwell, fever, cough, some productive, some non-productive, and they have shortness of breath. And also they complain of pain on coughing. They complain of chest pain on coughing. So that is called pleuritic chest pain. Pleuritic chest pain, that is the pleuritic chest pain means you get pain on coughing. That's called pleuritic chest pain. All right. And when you examine this patient, what are the physical signs that you will see over a pneumonia, a patient who has got pneumonia? So again, that side of the lung, where you got the pneumonia, the chest wall expansion, like can you see my chest went outwards and backwards, like it went like expanded, it went inside during expiration. So that's the normal respiratory movements. So the respiratory movements of the chest wall expansion is reduced on the side of the pneumonia. Also, when you auscultate with your stethoscope over the pneumonia, you will hear localized crepitations, crackles. Also, another very important physical sign that is called bronchial breathing, like that type of breath sounds. That's called bronchial breathing. So you get a bronchial breathing type of breath sounds when you hear over a consolidation or over a pneumonia. Consolidation is the respiratory diagnosis, and we call it pneumonia as the medical term, pathological term. And also when you auscultate with your stethoscope over the pneumonia, your vocal fremitus and vocal resonance is increased. See the difference between pleural effusion and pneumonia. Pneumonia, vocal fremitus and vocal resonance increased. Bronchial breathing, and there are crepitations, right? So those are the physical signs of a pneumonia. Constantly. Usually trachea is in the center. It's not displaced to any side when you get pneumonia, just pure pneumonia, right? So when you get a pneumonia, so when you clinically suspect pneumonia, you have to do a chest x-ray. And this is the chest x-ray of a pneumonia. Look at this patient. This is how you interpret. You can see in this patient. So I taught you how to interpret the lung fields in the chest x-ray. Here you can see the left lung is completely normal. The left lung is completely normal. But what about the right lung? Look at this. In the right lung, you can see that there's a white colored opacity. Can you see this? In the right lower zone, there's a nice white colored opacity. Right lower zone, there's a white color opacity. Is this as white as pleural effusion? No. See, in the pleural effusion, it's a uniform opacity. Pleural effusion, uniform opacity. But here, it is not a uniform opacity. Here you see more white color, but here is a white color with some black areas. Those black areas are the pathway of minute bronchioles or bronchiolar divisions. So that's called air bronchogram appearance. So it's a opacity. You can see the white color. White color is called opacity. Opacity with these black lines or black holes. So black lines or black holes are the cut sections. When you send the X-ray, those X-ray waves they go through these bronchioles. So in certain bronchioles, it will go like this. Certain bronchioles will go like this. So like lines or cut sections. So that's you will see are the rounds or lines. That's called air bronchogram. It's a radiological sign that you will see in the opacity. It's an opacity with air bronchogram. Air bronchogram. That's classical. That's classical of a pneumonia. Opacity with air bronchogram. So what is the diagnosis here? Right lower zone community acquired pneumonia. Look at this patient. And this patient again, the right lung. It's a very bad patient, isn't it? You can see entire right lung, right upper zone, right mid zone, right lower zone. All three zones. The entire right side of the lung is affected in that patient. So patient has got right side, upper, mid, and lower zone. community-acquired pneumonia. Can you see this white color? It's not uniform. In this white color, there are black areas, black lines, and black holes. So that's called AR bronchogram. This is a CT scan of a CAT scan or a CT scan of a patient with consolidation. You can see this is the opacity. It's a high dense area. You can see the hyperdensity. And in that, you can see this black lines. That's the AR bronch. Can you see this? Can you read this red sentence? That's AR bronchogram. So that is what I taught you. There's a radiological sign of a pneumonia. So in the CT scan also, you can see this AR bronchogram. These arrows are to AR bronchogram. So now you know how to identify consolidation in an X-ray or even in a CT scan. So you see opacity with AR bronchogram, these black lines. Okay, right. So now, and here I have explained all the physical signs of a pneumonia. Guys, this is not just X-ray class. It's just X-ray plus physical signs, causes, lots of theory. Almost you cover the respiratory system, but you have to learn more. I mean, this does not mean that you don't have to come to a class and learn. You of course you have to come to the class and learn, but in your whole life, this is a life lesson on X-ray, because usually there are no X-ray classes. This is a life lesson on X-ray. Even the day before, until the day you die, you take this knowledge, X-ray interpretation. Right. So you can see here another left upper zone right upper zone consolidation. If you see a X-ray like this, where you have got predominantly upper zone consolidation, few diagnoses you must think of. One is tuberculosis. In tuberculosis, you get upper zone consolidation. Tuberculosis, you get an upper zone consolidation. What did I say? TB, pulmonary TB, you get upper zone consolidation, upper area of the lung. Similarly, Klebsiella pneumonia. In Klebsiella also, you get upper zone consolidation. Remember that. Right. So this is the treatment algorithm of pneumonia. CAP stands for community-acquired pneumonia. So when you get a patient with pneumonia, you have to assess the pneumonia severity scores. There are different pneumonia severity assessing scores, like there's something called curve 65. You must read on these areas. Modified curve 65, C for confusion, U for uremia, C for confusion, U for uremia, R for respiratory rate. So C confusion, U uremia, blood urea more than 7 millimoles, R is respiratory rate more than 30, B is blood pressure, systolic blood pressure below 90, 65 is H more than 65. There are other multiple, severities parameters, like if you have got multiple comorbidities, multiple other pathologies, your prognosis is poor. If you have got more than one lobe involved in the chest X-ray, again prognosis is poor. If you got hypoxia, that is if your oxygenation is low, either your partial pressure of oxygen, that is PaO2, if that is low, prognosis is poor. If your saturation is low, prognosis is poor. Then you also have to see whether this patient has got any acidosis, respiratory acidosis, that is type 2 respiratory failure. Then also your prognosis is going to be poor. So these are the parameters that you have to see when you get a patient with pneumonia. Those are called severity assessment scores. So once you confirm a pneumonia with the chest X-ray, then you must start treatment immediately. So how do you treat a pneumonia? You, if the patient is acutely unwell, you have to take blood cultures as well. You have to take sputum culture. You take some sputum for culture. You take blood for culture, but you don't wait until the result comes, because culture report come only after 72 hours. So before, or 40 to 72 hours. So before the culture report comes, you take the blood culture and start on broad spectrum IV antibiotic. So what are the best guess antibiotic? If it is a severe community-acquired pneumonia, there are two combinations available, right? Number one, you can give IV ceftriaxone, IV ceftriaxone plus a macrolide to cover the atypical organisms like Mycoplasma, Legionella, and Chlamydia. That's why you are adding macrolide. What are these macrolide? Erythromycin, azithromycin, clarithromycin. Those are called macrolides. Erythromycin, azithromycin, and clarithromycin. Those are called macrolides. So either IV ceftriaxone plus, so it's all given here, the pneumonia treatment is from British guidelines. So you can see the risky SSD as well. And the combination of antibiotics that we give, all that is given in this chart. You can go through this leisurely later. So IV ceftriaxone plus a macrolide. We'll take azithromycin. So either IV ceftriaxone plus azithromycin, or you can give IV co-amoxiclav, that is amoxicillin plus clavulanic acid plus azithromycin. So any of these two combination, A, IV ceftriaxone plus oral azithromycin, B, IV co-amoxiclav, that is amoxicillin plus clavulanic acid plus azithromycin. So any of these two, either A or B, one of those combinations you can go ahead with. And so, and if the patient is having severe allergy to penicillin, then you can't give co-amoxiclav. Even if your allergy is very severe, type 1 severe allergic reaction, then you can't even give ceftriaxone. Then you have to give drugs like either IV gentamicin or IV ciprofloxacin or levofloxacin. That type of drug should be given if you have got severe penicillin allergy. Severe penicillin allergy, and if the patient is very unwell, we give either IV levofloxacin or IV gentamicin. Remember that. If it is just a mild, very mild degree of community-acquired pneumonia, where patient is walking, talking, quite a stable patient, only he has got some opacity, then you can even treat with oral antibiotics if the patient looks very well. So, and if the patient has got, so oral antibiotics, you can do oral co-amoxiclav plus azithromycin. But if the patient is allergic to penicillin, then you can only treat with oral macrolide, like oral azithromycin, or you can give doxycycline, any of those things. So I covered a lot of pharmacology also there. And remember guys, these are lots of questions which have come up in the single best answer paper. If you go through the questions, if you've gone through the questions, you will realize that this has been asked. Right. So various physical signs in lung disorders I have given in this chart. It's a summary of physical signs that you get in lung disorders. So this is something that you need to go through. I added this slide for you to read and understand. I have uploaded this presentation. This presentation, I added new slides. So I uploaded to you all these WhatsApp groups today as fresh thing, fresh presentation. Then comes another infection of the lung that is called lung abscess. What is an abscess? Abscess means a pus-filled cavity, pus-filled, fluid-filled cavity. That's called an abscess. So in the lung also you can get abscess in the brain, you can get abscess in the lungs, you can get liver abscess, kidney abscess, renal abscess, like that, bone abscesses. You can get abscesses in anywhere of the body. So this is a lung abscess. So you can see here in the lung abscess, it's a rounded opacity. It's a rounded lesion. Can you see the rounded lesion here? It's a rounded lesion. Here there's another nice rounded lesion. It's not nice to the patient though. It's nice to the doctor, but not nice to the patient. It's very, serious condition. Patient is very looking. And here you can see another rounded lesion. Can you see the appearance is rounded? Here it's rounded. It's rounded here. Rounded lesion. Rounded lesion. And in this rounded lesion, what do you notice? On top you see air, black color, and on bottom you see fluid. Here, this fluid, which is white color. See this rounded lesion. On top you get air, on bottom, in bottom you get this fluid. Fluid is flat. Here you can see air in red color, fluid in yellow color. Again, this is the rounded opacity. Air on top. Sorry, all this is air on top, and fluid here in the bottom part. So air, fluid. So this is a rounded opacity, air on top, fluid in bottom. So air, fluid, there's an air fluid level, rounded opacity with the air fluid level, air fluid level. Can you see that beautifully? Rounded opacity with air fluid level. This is the fluid level. So definition of an abscess is it's a rounded opacity with the air fluid level. That is an abscess. Patient is very ill if you get a lung abscess. What are the clinical features? Very high fever, and they get shivering, shakes, chills and rigors. They get shakes. Very high fever spikes. Like fever spikes will be like this in the fever chart. Very high fever spike. Very unwell, acutely unwell patient. His eating, drinking, everything is affected. And you get some physical signs over the lung abscess. That is, you get reduced chest wall expansion. There will be localized crackles, and there you can also hear a bronchial breathing. Sometimes, not always. There's some compression of the peripheral bronchus. You also might hear bronchial, but that's not an important sign. But mainly you will hear crepitations. Right. So this is how you visualize a lung abscess in a chest X-ray. And if you see a lung abscess, how do you treat that? You have to take a blood culture, and also you need to start on broad spectrum IV antibiotics. And usually we treat for a minimum period of 14 days. 14 days, such a serious condition, lung abscess. It's like empyema. Empyema is a pus in pleural space. That is also very serious condition that we put IC to drain the fluid and also give IV antibiotics for 14 days. Similarly, lung abscess also, you don't put drains, but you give IV antibiotics for 14 days duration. Right, so clinical features I have mentioned, and also in lung abscess you can get hemoptysis. That's important to remember. Lung abscess can cause blood-stained sputum called hemoptysis. So all these clinical features I have mentioned. Bronchial breathing, if there's peripheral bronchi being compressed, you can get bronchial breathing. Clinic investigation of anomalies like neutrophil leukocytosis, very high ESR, very high CRP. Why? Such a serious condition. There's serious infection. So ESR and CRP can be very high. Blood cultures will be positive. So broad spectrum IV antibiotics, I have given you combination of antibiotics. So abscess, if you have got an abscess, we go for a combination of IV, either IV coamoxiclav or IV ceftriaxone, but you must always combine an anaerobic cover. Why? Abscesses are mainly formed by anaerobes or plus gram-negative organisms. So we always add IV metronidazole to cover the anaerobic organisms. Right. I think last class we stopped at lung abscesses. Is that correct? So today we are starting fresh from this topic onwards. So this bronchiectasis. So in the lungs, you also get another radiological diagnosis, a respiratory disease called bronchiectasis. What is bronchiectasis? Bronchiectasis is where you get permanent dilatation. So there's persistent infection, inflammation, which causes permanent dilatation of the end or the terminal bronchioles. Now you know our windpipe, it comes as trachea, then you have the two bronchi, then there are dividing branches of bronchi. These bronchi, they divide into various sub branches, various tiny branches. So these bronchi divide that. Ultimately, they divide in terminal bronchioles and they end up in alveoli. Terminal bronchioles or end bronchioles. See, these bronchioles, there's a persistent infection and inflammation going on. There's persistent inflammation. So that persistent inflammation of those end bronchioles, that will cause permanent dilatation. And when you get permanent dilatation, you know the clearance of secretions in those bronchioles, they are affected. So if the clearance of secretions, like when you like that, you all the time you cough out secretions and put it out. But in these people, you can't do that, and that will cause persistent infection of his bronchioles and inflammation, and that causes very thick, khaki colored and purulent sputum, right? In this condition called bronchiectasis. So see, guys, these X-rays, these are clinical features or radiological features of bronchiectasis. But before that, I will teach you more clinical features of bronchiectasis. So what are the clinical features? What is the pathology first of all? As I told you before, there's persistent inflammation of the end or terminal bronchioles, which cause permanent dilatation of the bronchioles. What are the clinical features? You get thick, purulent, yellowish or brown colored sputum. Thick, yellowish, brownish, or we call it khaki colored sputum when they cough. They have productive of all the time they cough out sputum. It's very offensive. So brownish, thick, yellow, sticky sputum. And this is very smelly. It also produces a bad smell in their breath that is called halitosis. Then also the sputum is usually blood stained. So they have hemoptysis. They have hemoptysis. Then also uh, uh, these patients are very ill looking because they have this persistent infection and inflammation. They are very ill looking, and also because of this persistent hemoptysis, they end up with iron deficiency anemia. Iron deficiency anemia. Okay, right. So those are clinical features of bronchiectasis. When you examine the patient in your fingernail, this will be curved, what you call finger clubbing. So finger clubbing will be there in these patients. Okay. And also, when you examine their lungs, when you auscultate their lungs, what are the physical signs that you can listen? When you auscultate their lung bases, you can hear coarse. Remember the word that I'm using, C-O-A-R-S-C, coarse crepitations in their lung bases, coarse crepitations in their bilateral lung bases. Also, you can hear patches of bronchial breathing. Very important. 3 physical signs I told you. What are they? Finger clubbing, bibasal coarse crepitation, because there are certain respiratory diseases like fibrosing alveolitis where you get clubbing but bilateral fine crepitations. Fine crepitation. But here what you get is in bronchiectasis you hear coarse crepitations. Then also you will hear patches of bronchial breathing. Patches of bronchial breathing. Right? So those are the clinical features of bronchiectasis. And remember, as I told you before, their sputum is very offensive, thick, brownish, khaki colored, infected sputum. They also have halitosis and hemoptysis. What are the causes of bronchiectasis? The commonest cause in the whole world is cystic fibrosis. In Sri Lanka, you have tuberculosis. Childhood infections like measles, pertussis, they can cause adulthood bronchiectasis. If you got lung fibrosis, fibrotic lung disease, that can cause bronchiectasis. Then also, there are other rare causes which you don't have to know, but also you have to remember there's a condition called cartilaginous syndrome. That is where you get dextrocardia. Now, usually your heart is on the left side, but here the heart will be on the right side, so that you call as dextrocardia. So there's dextrocardia, then patient will get bronchiectasis and also purulent sinusitis. Dextrocardia, bronchiectasis, and sinusitis. And that comprises syndrome called cartilaginous syndrome. Cartilaginous syndrome. All right. So these are causes of. So see, guys, I covered the entire bronchiectasis. This is not just X-ray class. Right. So in this bronchiectasis, what do you see in the chest X-ray? So as you can see here, these are different, slides of X-ray films of bronchiectasis. So this is a chest X-ray of a patient with bronchiectasis. You can you see this arrow? So pay your attention to these arrowed areas. Here you can see a black line, and here you see black holes. Can you see a black hole here? It's a black hole or black rounded area. It's a black rounded area. It's a black rounded area here, black round, and black lines. So these are called tram line shadows and signet ring appearance. See, these are tram line, so parallel lines, 2 parallel lines. Tram line or tram track shadows, and this is called signet ring, surrounded, signet ring appearance, called signet ring appearance. So tram line shadows and signet ring appearance that you will see in the X-ray. So that is the early stage of bronchitis. So you will see a white color opacity with these tram line shadows and signet ring appearance. But in the X-ray, it's not that prominent. The best way to diagnose bronchiectasis, or we call it investigation of choice, that is your CT scan. What CT scan? HRCT, or what you call high resolution CT scan. So this is a high resolution CT scan. You can see this signet ring appearance here and tram line shadow. This here there's a bit of honeycombing as well. The honeycomb, Miva there. So here this is another HRCT. You can see a beautiful honeycomb appearance here. Beautiful honeycomb appearance in this CT scan. So this is another bronchiectasis. You can see multiple honeycomb shadows. This is another X-ray which shows all these advanced bronchiectasis with honeycomb shadows. So a lot of cystic areas. You know, in a honeycomb you get these holes like areas, cystic areas. So you can see these cystic areas or like honeycomb appearance in the chest X-ray. This is another honeycomb appearance of chest X-ray in a patient with bronchiectasis. So remember, guys, what are the radiological diagnoses of bronchiectasis? The early findings are you will get opacity with tram track or tram-line shadows with signet ring appearance, and later they progress up to this honeycomb appearance, multiple cystic shadows. Okay, so that is how you diagnose bronchiectasis. Initially chest X-ray, but the best investigation or the investigation of choice is HRCT. So all the clinical, the causes of bronchiectasis I have mentioned here, which I taught you earlier. Clinical features I have mentioned, the physical examination findings I have mentioned, HRCT findings, the signet ring and the tram-line shadows, finally cystic honeycomb appearance. So what is the treatment of bronchiectasis? You need to give antibiotics to treat the infection. And the chest physiotherapy is so important. You put the patient head low like this, your head low. So that is called postural drainage. We use the posture to drain all these infected sputum. So that is called postural drainage and physiotherapy, chest physiotherapy with postural drainage. And if you got local bronchiectasis, you can do surgery, but usually it's difficult. So you have to go for antibiotics, postural drainage, things like that. Right. Now we come to so we have discussed infections, we have discussed pneumothorax. Now we are moving on to cancers of the lung carcinoma, cancers of the lung carcinoma, right? Lung carcinoma. So how do you see a cancer or a carcinoma in the chest X-ray? So lung carcinoma is a rounded opacity. It's again a rounded opacity, right? It's a rounded opacity. So it's a white colored lesion which is rounded. So if you see a rounded opacity in a chest X-ray, think of whether it's a lung cancer. So can you see this? So this is a rounded opacity. Can you see this rounded opacity here? And another rounded opacity here. Another rounded opacity here. Rounded opacity here. And here, look at this. This is funny, isn't it? It's weird. There are multiple small rounded opacities here in this X-ray. Why is that? This one is different to this X-ray. So the X-ray on top, that is where you got a primary lung cancer. It's a primary lung carcinoma. Can you see this? It's one single tumor. It's a primary lung carcinoma. And here you see multiple deposits, multiple white color opacities, and those are the secondaries. So remember this, guys. It's a take-home X-ray message, radiological message, right? The top X-ray is a rounded opacity or a primary lung, primary. That's the cancer is in the lung. So primary lung carcinoma, like what you call bronchial carcinoma. It's a bronchial carcinoma, right? And this one, this is the cancer is somewhere else. Maybe a thyroid cancer, maybe a breast carcinoma, maybe a kidney, renal carcinoma. And they are, right? So I hope you can see me clearly. Yeah. Okay. So in these conditions, primary cancer is somewhere else, and the secondary metastatic deposits have occurred in the lungs. Where else can you get secondaries in the body? Secondary metastatic deposits. You can get secondary metastatic deposits in the lungs. You can get in the liver. You can get in the brain. You can get in the bones, and you can get on the adrenal glands. So secondaries can occur on the liver, in the lungs, in the brain, in bones, as well as in the adrenal gland. So these are the places where you can get secondary deposits from some other cancer somewhere else in the body. Okay, so when you get secondary metastatic deposits in the lung, it has a peculiar appearance. When you get secondary deposits in the lung, there's a peculiar appearance. It's like multiple balls. Here, can you see multiple balls? So these are called cannonball metastatic deposits. So we give a term called cannonball metastatic deposits. So this is a patient with cannonball secondary metastatic deposits in the lung. And this is a primary lung cancer, what we call bronchial carcinoma. Guys, so this is a CT scan. Can you see So confirmatory. So when in the chest X-ray, if you detect a lesion like this, if you detect lesions like this, we always go for a CAT scan, CT scan. Why? We want to have a better visualization of the cancer. So we go for a CT scan, and CT scan you can see this rounded opacity in a better way. And if you suspect something like this in the CT scan, our next procedure is we call the respiratory physician to do a bronchoscopy. So you can see they pass this tube through their nose into their bronchial windpipe, and they go inside and they try to visualize the ultimate site through the screen. You can see where the cancer is. And guys, one more thing, you can remember in my respiratory medicine lectures, if you get an upper zone cancer here, apex of the lung, the upper zones of the lung or the apex of the lung, if you get a cancer, what do you call that? That's called, yes, Pancoast tumor. That's called a Pancoast tumor. What are the clinical features of Pancoast syndrome? Can you remember this as a revision I'm telling? So if you got Pancoast syndrome, you damage your sympathetic chain here in the root of the ring. You also damage the medial cord of the brachial plexus. So due to damage to the sympathetic chain, you get the same site, Horner's syndrome. So what are the clinical features of Horner's syndrome? You get ptosis, upper eyelid is falling down. That's called ptosis. The pupil is pinpoint, small tiny pupil. That's called meiosis. So ptosis, meiosis, pinpoint pupil, upper eyelid falling down, ptosis. And that half of the face, your sweating is absent. Sweating is absent. What is that called? Anhidrosis. So these three features comprise a condition called Horner's syndrome. So that's due to the damage to the sympathetic chain. Also due to damage to the medial cord of brachial plexus, you will get pain along the medial aspect of the arm. Along the medial aspect of the arm, you will get pain. And also patients, this medial cord of brachial plexus that has C81 fibers. So your these small muscles of the head, like the thumb area, the abductor pollicis brevis, and also these dorsal interossei of the head, they'll be wasted and there'll be weakness on the same side. We will have wasting and weakness of the small muscles of the head due to this brachial plexus injury in patients with Pancoast tumor. And also your upper ribs, the first rib and the second rib, they can get destructed in Pancoast tumor, Pancoast syndrome, which I have taught in the respiratory medicine lectures. All right, so that's about lung cancer. Just a little more theory about lung cancer. What are the causes of lung cancer? The commonest cause of lung cancer is divided as small cell, non-small cell. Small cell cancer is an endocrine tumor. It's also called oat cell carcinoma. The non-small cell lung cancer is divided as squamous cell carcinoma. Squamous cell carcinoma is the commonest one. Adenocarcinoma, then alveolar cell carcinoma, and also large cell carcinoma. But the more important ones that you need to remember is squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is the commonest cause of bronchial carcinoma, lung cancer, and that is associated with cigarette smoking. Asbestos exposure causes adenocarcinoma. Right? Those are all MCQ points. Right? Yeah. So all those clinical features I have mentioned. History of exposure to asbestos, cough, hemoptysis. So what are the clinical features of lung cancer? So they get a persistent cough with hemoptysis. Persistent cough, like a long-standing cough with hemoptysis. And maybe dull, aching chest pain, also pleuritic chest pain. And they will have loss of appetite, loss of weight. Another feature that they get is they get change of voice. Why is that? The lung cancer is close to your bifurcation of the trachea. So there you have the arch of aorta, and also you have the recurrent laryngeal nerve arching through that. So if you got a lung cancer here, close to your hilum, and also close to your division of main bronchus, division of the trachea, there the recurrent laryngeal nerve can get damaged, and that will cause vocal cord paralysis, and patient will end up with hoarseness of voice or change of voice. So remember, that's a very important physical sign to suspect lung cancer. Clinical features of Pancoast syndrome I have mentioned, Pancoast tumor, and also when you get lung cancer, you can get finger clubbing. Also, you can get a lot of endocrinological manifestations in lung carcinoma. Those are called paraneoplastic syndrome, or the other term is hypertrophic. Other term is non-metastatic extrapulmonary manifestations of bronchial carcinoma. Non-metastatic extrapulmonary manifestations of bronchial carcinoma, or we call it paraneoplastic syndrome. You can get various endocrine manifestations like SIADH, ectopic ACTH secretion causing Cushing syndrome. You can get hypercalcemia. You can get hyperglycemia. You also can get various neurological disorders like Eaton-Lambert myasthenic syndrome. You can get muscle weakness called polymyositis, sometimes polymyositis with a rash, you call it dermatomyositis. I mean, these are little difficult areas. Like in this online class, you can't cover all that. For that, you have to come for the proper regular classes. But I'm just giving you hints up, like how the lung cancer can appear in a chest X-ray and what are the critical features, what are the causes of lung carcinoma. So I told you the investigations: chest X-ray, CT scan, and also bronchoscopy. So what are the therapies available? If it is a small lung cancer, localized one, you can go for surgery. But also most of the time when they come, they are in advanced state. Therefore, you have to go for palliative radiotherapy or chemotherapy, a palliative approach for those patients. Right. So now we are moving away from lungs. Now we are moving on to heart diseases. Now, when you get heart diseases, that also can be seen in a chest X-ray. Like the best one that you need to know is your heart failure, right? Heart failure. So when you get a patient with heart failure or congestive cardiac failure, there are certain X-ray appearances that you need to know. So there are five radiological signs that you need to know to diagnose heart failure in a chest X-ray. And this you have to know. They have asked this in the X-ray. What are they? Number one, the cardiac shadow that's increased. Can you see the width of the heart shadow that is increasing? Width of this is a better one. It's a better X-ray. Can you see the size of the heart? Size of the heart is quite big. It's more than half of the thoracic cage. Here you can see the cardiac shadow is increased. So this is the cardiac ratio, this is cardiac diameter, this is the thoracic diameter. You divide this by this, it is more than 0.5. So you can see your CT ratio more than half. Can you see? Can you read this in red? CT ratio more than half, you call it cardiomegaly. That's number one. So when you get this chest X-ray, first you look at the media stadium. Look at this media stadium. What is the most important structure? The heart. The heart shadow is increased, is enlarged. So you call it cardiomegaly. Cardiothoracic ratio is more than 0.5. Then you look at the lung fields. The lung fields, what do you notice? The first change is, can you see these arrows upwards? Can you see these arrows going up? I don't know whether you can see that properly. I'll show you better. Here we go. Can you see these arrows? Green color, they have marked in green color. The arrows going up. Here another diagrammatic explanation, the arrows going up or the blood vessels going up. So here actually if you follow this chest X-ray carefully, you can see some arrows, the blood vessels, they are going up. And here also you can see here blood vessels going up. And that is called upper lobe diversion. What is it? It's called upper lobe diversion. That's the first feature that you get. Upper lobe diversion. So the in the lungs, the first feature that you see in the X-ray of the lung fields is the blood vessels in the upper part of the lung, they are going up like this, directed upwards. That's called upper lobe diversion. Can you see here? It's diagrammatically it's explained here. It's going up. Here it's going up. That's called upper lobe diversion. Here, upper lobe diversion, blood vessels going up. Here in this X-ray, you can clearly see that here, upper lobe diversion here, particularly this here. Then around the heart, you can see there's prominent vascular markings. Can you see? It's like bat wing. Can you see a bat wing here and here another bat wing appearance? So that's called perihilar. That's around the heart. You see whitish shadows. That is called bilateral hilar shadowing or bat wing appearance. Can you see one bat wing here, another bat wing here, one bat wing here, another bat wing here? So here these are bat wing appearance. Or here you can see one bat wing here, another bat wing here. So this is called perihilar, around the hilar. Perihilar shadowing or bat wing appearance. That's number two. Number three, you get certain lines. You get parallel lines or horizontal lines here in the lung fields like this. You get horizontal lines like this. Can you see these orange lines in the periphery? Can you see these lines? These are called curly bee lines. These parallel lines horizontally, they are called curly bee lines. Can you see this here? I don't know whether you can see that properly here. they are called curly B lines. Parallel lines at the bottom of the lung, they are called curly B lines. They are all marked here, curly B lines here, curly B lines. So if you have gone through this presentation, that would have been an easier exercise for you all. I uploaded much earlier. So I hope you need to go through these things, not just participating in this lecture, but you also have to go through these things. So those are called curly B lines. That's the third feature in the lung field. Then the fourth feature in the lung field is you can get a pleural effusion. Here, can you see this costophrenic angle that is blocked? The costophrenic angles, they are obliterated. Here, see, in this costophrenic angle, there's fluid. This costophrenic angle, there's fluid here. So there's a pleural effusion. So what are the 5 features of heart failure in a chest X-ray? Number 1, cardiomegaly. Number 2, upper lobe diversion. Number 3, perihilar shadowing, or what you call batwing appearance, the heart batwing appearance. Number 4, curly B lines. And number 5, pleural effusion. So these are the clinical features. These are the radiological features of heart failure. What is the confirmatory test of heart failure? It is not the X-ray, but what is it? 2D echocardiogram or transthoracic echo. Confirmatory test to diagnose heart failure is transthoracic echo or 2D echocardiogram. So heart failures are divided into 2 parts. One is called heart failure with preserved ejection fraction, or what we call diastolic heart failure. The other category is called heart failure with low ejection fraction, and that is called systolic heart failure. Okay, heart failure with preserved ejection fraction, that is where ejection fraction is normal. It's called diastolic dysfunction. And the other one is heart failure with reduced ejection fraction or low ejection fraction, and that is called systolic heart failure. What are the clinical features of heart failure? So the people with heart failure, they present with shortness of breath. Why? There's fluid in the lungs. Here you can see all this is fluid. Here, lungs are full of fluid. So when there's fluid in the lungs, you feel short of breath. Your oxygenation is poor. So that causes shortness of breath, dyspnea. So initial stage of dyspnea, it is called exertional dyspnea. They complain, I can't walk some distance, I feel short of breath. I can't climb a staircase, I feel short of breath. So that is shortness of breath on exertion. You also can get, when the patient lies flat, you can become very short of breath. What is that called? Orthopnea. So they tend to keep about 2-3 pillows when they sleep. They increase the number of pillows. That is called orthopnea. Then also, in the middle of the night, when they are sleeping, they are woken up with frightening experience due to this severe shortness of breath. And that is called paroxysmal nocturnal dyspnea. So exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Right? What are the other clinical features you get in heart failure? You also get edema. So if you look at their ankles, like if you press this area, you can see that they have got ankle edema. They've got swollen feet, ankle edema. And if you have got, and what are the physical signs? When you auscultate their lungs, when you put the stethoscope on their chest, you can hear bibasal fine crepitations. Now in bronchiectasis, I taught you bibasal coarse crepitations. And here you will hear bibasal fine crepitations. Fine crepitations. Also, if the patient, so that is if you have got more symptoms of left heart failure. If you have got more symptoms of left heart failure, you get bibasal fine crepitations. If the patient has got more features of right heart failure, because you know in the heart there's left side of the heart, right side of the heart, left ventricles, right ventricles are there. If you got more features of left heart failure, you get bibasal fine crepitations and dyspnea. If you got more of right heart failure, you get edema, and also your JVP in the neck, jugular venous pressure. Jugular venous pressure will be elevated. JVP will be elevated. Okay, I covered lots of clinical features of heart failure and all the radiological features of heart failure. Okay, guys, it's beyond X-ray interpretation. It's not just X-ray medicine, it's beyond X-ray interpretation. So, so yeah, the clinical management of heart failure I have mentioned here. If the patient has got heart failure, if you got acute, so here I have mentioned management of acute heart failure. I have drafted that for your benefit, so you must go through these things. Done a lot of effort making these presentations, and remember guys, these are not free of charge. You know, you won't get like this anywhere else in the world, right? Like these X-ray classes, making these slides and doing these presentations. Okay, So like then you can understand this what the amount of effort that we have put in to do these presentations. And once we start the regular classes, make maximum use of us, and also try to pass the exam in one shot. Right. So here you can see management of heart failure. What I told you before, you can see management of acute heart failure. So if the blood pressure is high, so how do you manage a patient with acute heart failure? If the patient's systolic blood pressure is more than 100 or 110, then you can give them intravenous diuretics, IV furosemide. You give IV furosemide. You can start with the 40 milligrams bolus dose. The patient comes with acute heart failure, and if his blood pressure is more than 110, systolic pressure more than 110, or usually we take more than 100, you can give intravenous furosemide. If the patient's blood pressure is very high, like systolic blood pressure very high, like maybe 170, 180 like that, then instead of IV furosemide, you can start on IV GTN, that is IV nitrate infusion. So what did I say? If your blood pressure is above 110 and if you have got acute heart failure, you can treat that patient with IV furosemide. If your blood pressure is very high, then not only you treat the heart failure, you also have to control the blood pressure. So giving IV furosemide itself is not enough. So therefore, you control the blood pressure plus reduce the heart failure. For that, you have to give IV nitrate. What about if the patient's blood pressure is low, like if the systolic blood pressure is below 85 or something like that? If the patient's systolic blood pressure is low, then you can't give furosemide, you can't give nitrate. Then you have to start on inotropes like IV Wotable and put them on non-invasive ventilators, CPAP. So these things, guys, we can't explain here. You have to come for lectures. Those lectures we will teach you. So with this X-ray class, I just went ahead with management of heart failure, because heart failure itself is a big topic. Right. So all that is mentioned here, summarized here as well. What are the drugs with survival benefits in heart failure? Another MCQ question I'm covering. Yes, what are the drugs with survival benefit? You have to give ACE inhibitors. Why? Because you have to reduce the load to the heart. You have to give a drug which will reduce the preload. So that's a venodilator, ACE inhibitors. Then also you have to reduce the peripheral resistance. So by causing vasodilatation, you reduce the peripheral resistance. So that is to reduce the preload and to reduce the peripheral resistance, you give a ACE inhibitor like enalapril or angiotensin receptor blocker like losartan. Then number 2, you have to reduce the sympathetic stimulation in heart failure. The sympathetic nervous system you have to reduce, suppress. So for that you have to give beta blockers. What are the beta blockers? Carvedilol, bisoprolol, metoprolol. Atenolol also you can give. So those are the drugs that you use as beta blockers. Then if you got heart failure with low ejection fraction, if it is less than 0.45%, then you also have to give aldosterone antagonism, a drug to block the aldosterone, because aldosterone retains salt and water. So what is the drug that you give? Spironolactone. So you can give spironolactone to block the aldosterone if you got heart failure with very low ejection fraction, below 45%. Right. So that finishes your chest X-ray pathological conditions. So chest X-ray abnormalities I have completely covered. Right. Actually, most of the all medical conditions I have gone through. Now we are going to go through another few more abnormalities that you see in a chest X-ray. Actually, these are surgical conditions. So there's a condition called perforated viscous causing gas under diaphragm. Earlier I told you there shouldn't be anything under the diaphragm. Under the diaphragm there shouldn't be any gas. Now below the right diaphragm, what you see is the liver. So there should be white color. But what has this patient got? There's a can you see a slit of air, black colored slit of air below the right diaphragm? So there is gas. Gas is always, or air is always black colored. There's a slit of air under the right hemidiaphragm. So that is called gas under diaphragm. Dangerous. Why? Either maybe he has got ruptured appendix, or maybe he has got ruptured bowel loops, causing leakage of air in this hollow structure, which will go up and stay below the diaphragm. Gas under diaphragm. Now don't get confused with this one. This is the gastric air bubble, which is normal. In you and I also, we have the gastric air bubble. Our stomach is filled with some air. On the left side, it's normal, but this is like it's taking the shape of the diaphragm, a slit like air under diaphragm. So gas under diaphragm is a very ominous, very significant physical sign, radiological signs. You can see another gas under diaphragm here, actually bilateral. You can see bilateral gas under diaphragm below the left heavy diaphragm, below the right heavy diaphragm. And this is the gastric air bubble separately. Here I'm showing that gastric air bubble separately, but these are gas under diaphragms. And this another chest X-ray, you can see this again gas under diaphragm. So gas under diaphragm is a dangerous radiological sign, and you have to always summon the surgeon. You have to keep the patient kneel by mouth, start IV fluids, and get the surgeon. Maybe you have to go through a very urgent ultrasound scan of abdomen, also a fast scan, and maybe this is due to ruptured appendix or ruptured viscous, like ruptured bowel. So you most of the time, if you have seen gas under diaphragm, you have to go for emergency laparotomy. And it's a surgical condition, surgical emergency. But you should never miss this physical sign. What is it? Gas under diaphragm. So what I have done is I have trained your eyes never to miss this. Because if you miss this as a doctor, you will be in the prison. Why? It's a medical negligence. But from today onwards, it won't happen. Right. So there is perforated viscous causing gas under diaphragm. Right. Then another surgical condition. Now we are moving on to abdominal X-rays. Right. Chest X-rays over. Now abdominal X-rays. X-ray abdomen. When you take X-ray abdomen, if you see something like this, what do you see this? You will see multiple air fluid levels. Now in the lung abscess also, I taught you air on top and a fluid level at bottom. So multiple, here there's one air fluid level. Can you see? Air like this, air fluid level, like this, air fluid level. So here you see one air fluid level, one, another air fluid level, another air fluid level, another one. And this side, multiple air fluid levels. So if you see multiple air fluid levels in the X-ray abdomen, that is suggestive of intestinal obstruction. What did I say? You see multiple air fluid levels in an abdominal X-ray that suggest intestinal obstruction. Can you see here in the second X-ray, another multiple air fluid levels, multiple air fluid level. Fluid level is always flat. Yeah, fluid level is always flat. Here you can see multiple air fluid levels. Here also you can see multiple air fluid levels. And this third X-ray, another beautiful abdominal X-ray showing multiple air fluid levels. Air, and see this fluid level is fully flat. Multiple air fluid levels. Multiple air fluid levels. So this is again a very dangerous radiological sign. So emergency situation, you must immediately summon the surgeon. You have to keep the patient kneel by mouth. Patient in this situation, patient will come with severe abdominal pain, or what you call severe acute abdominal pain. Patient might have guarding, rigidity in the abdomen. The bowel sounds will be diminished. And also a patient might complain that he has not passed, flatus for some time, right? And also there can be vomiting, recurrent vomiting. So those are features of intestinal obstruction. It's a surgical emergency. So you must immediately plan for surgery. So therefore you have to call the surgeon. But as a doctor, you should never miss this physical sign. So in the patient with severe abdominal pain, if you do X-ray abdomen and if you see these multiple air fluid levels, that's also a very ominous physical sign, and that's that suggests that you have to go ahead with emergency procedures, and you have to call the relevant authorities like surgeons to do a surgery. Right, next one. And then again in the X-ray abdomen, you can see another important radiological sign. In the X-ray abdomen, there's another important radiological sign. That is, when you take the X-ray abdomen, now can you see there? Here, now this is the lower margins of the ribs, and this is the vertebral column. This is the thoraco, and this is the lumbar vertebra. This is thoracic vertebra, these are lumbar vertebra. And can you see across this vertebra, There's some white colored, tiny, 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 like small sand, like white colored opacity is going. So if the vertebra is like this, it's going like this, right? It's crossing the vertebra. Can you see white colored tiny opacities crossing the vertebra from right side to the left side across the abdomen? What is the structure here? That is your pancreas. So those are what we call pancreatic calcifications. That's called pancreatic calcifications. So this is a calcified pancreas. Why do you get calcified pancreas? That is when you get chronic pancreatitis, not acute pancreatitis, but chronic pancreatitis. So when you get chronic pancreatitis, you can get this calcified pancreatic, calcified pancreas. So that is called calcific pancreatitis, chronic pancreatitis. You can see pancreatic calcification, which is crossing across the abdomen over the vertebral like this. You can see that shadow crossing the vertebral shadow. Okay, so can you see these multiple here, very faint white colored opacities here? Can you see these white colored shadows here? White colored shadows here. Here, this is the pancreatic head, this is the body, and this is the tail. Head, body, and tail. You can see another pancreatic opacities here. Can you see these pancreatic opacities, pancreatic calcifications crossing the abdomen across the vertebra? Here you can see a close-up view. Can you see these pancreatic calcifications, white colored calcified nodules here, white colored calcified nodules. And this is a CT scan showing calcified pancreas. So never miss this physical sign. It is not an emergency. It is not a medical or surgical emergency, but you should know if you have a patient with chronic pancreatitis, like chronic abdominal pain, chronic epigastric pain. He also gives a history of heavy alcohol consumption in the past. Think of chronic pancreatitis. How do they present? They present with chronic abdominal pain. They have steatoria. Why? They have features of malabsorption syndrome. Because you know in pancreatic insufficiency, you have exocrine pancreatic insufficiency. You know pancreas, they have exocrine outer part and also endocrine inner part. So exocrine pancreatic insufficiency, that causes reduction of lipase hormones and also various protease hormones. So your lipid absorption is impaired. So you pass all your lipids in your stools. That makes it a bulky, offensive color stools called steatoria. So because there's lack of lipid digestion and absorption, fat soluble vitamins like vitamin A, D, E, K, vitamin A, D, E, K, they are not absorbed. So vitamin A deficiency will cause night blindness. Vitamin D deficiency will cause hypocalcemia, osteomalacia, and fractures. Vitamin K deficiency can cause impaired clotting factor, and that will cause bleeding. Okay, so these you learn in our gastroenterology lectures, right? So what is the commonest cause of chronic pancreatitis? And that is exocrine pancreatic insufficiency. Endocrine pancreatic is because pancreas is an endocrine organ as well. So endocrine pancreatic insufficiency, the beta cells, Langerhans cells, they get atrophic and your insulin production is low. So you end up with diabetes. So they have to be on insulin as well. So to treat these patients with chronic pancreatitis, we give them pancreatic supplements. Pancreatic supplements. So the commonest cause in the whole world of chronic pancreatitis is heavy alcohol consumption. So never miss this physical sign. Across the abdomen, you can see white colored nodules going across the, or crossing, like perpendicular to the vertebral column. This chronic pancreatitis. White colored shadowy, white colored shadowy, white colored shadowy. Right. Next, X-ray abdomen. The last slide. Yes, the last. Oh no, few more slides. Sorry, because I updated this. So this is another X-ray abdomen. This X-ray abdomen we have done for almost 1.5 hours now. It's okay. So this X-ray abdomen, you can see now in this one you also see few more opacities. Can you see one opacity here at the margin of the lower rib? That is the margin of the 12th rib. Here you see more white opacities like a tree in the 12th rib appearance. And here in this X-ray, you see another white opacity, like elongated white opacity along the vertebral column. So what are these? These are stones. What stones? The kidney stones and the ureteric stones. So you can see the kidney. This is the kidney. Can you see the outline of the kidney here? So this is the kidney. Kidney lies close to your 12th rib, right? So this is your 12th rib. This is your 12th rib. So at that area you have your kidneys, and if you got renal stones, or what you call nephrolithiasis, renal stones, then you can see a white color opacity here. Then this is also 12th rib. So near 12th rib you have the kidneys, and here what have you seen? A tree-like appearance. It's like staghorn. You have seen the stag, no? So the deer, the stag's horn. So it's like staghorn appearance. You can see they're like tree bud appearance or staghorn appearance. So this is called a staghorn calculus. It's called the staghorn calculus. Large one, a big one. And this is another staghorn. So this patient has got bilateral staghorn calculus in the renal pelvis. So your renal pelvis lies at the 12th rib area. So bilateral staghorn calculus. This is just a renal stone, but these are staghorn calculus. And this is the structure of the ureter. So these are the kidneys lie here, and from the kidneys, the renal pelvis, you have the ureters coming down like this. These are the ureter coming down like this. So along the margin of the ureter, if you see a white color opacity, there is a ureteric stone. What are the clinical features of ureteric stone? Uretery. Here in the ureter, if you get stone, you get a severe colicky pain, severe abdominal pain. What do you call that? Ureteric colic. Ureteric colic. How do they complain? They complain of loin to groin pain. Loin to groin pain. So they complain of severe loin pain, and it's radiated to their low abdomen. It's called loin, or towards their groin. Loin to groin, colicky, like squeezing type of pain. It's called loin to groin, colicky abdominal pain. Severe abdominal pain. Usually you need to give strong pain relief medications, analgesics like intramuscular pethidine, or sometimes morphine. That type of strong pain relieving analgesic should be given. So it's surgical emergency as well. And these are renal stones. So when you get renal stones, you get a dull aching pain in your loin area. So kidneys are here in the loin region. So you get a dull aching pain in the loin region. All right. What are the common stones? Calcium oxalate stones. What are the other types of stones? You have the triphosphate stones, that is magnesium, calcium, and ammonia phosphate. The triphosphate stones. So that's your staghorn calculus. Then you have your cystine stones, urate stones. You know, urate stones are radiolucent. Right? So these are different types, but among all the causes of stones, the commonest cause is calcium oxalate stones. What are the common causes of stone formation? So hypercalcemia and hypercalciuria. So conditions like hyperparathyroidism, hypervitamin D, you must think of. Renal tubular acidosis, they all can cause renal stone formation. Severe dehydration, recurrent urinary infections, they all can lead to stone formation. You must know that. Right. This is about stones. X-ray abdomen over. Right. The bone X-rays. Now, guys, there are certain conditions which can cause abnormalities in bones. I'm not going to cover the surgical areas, because that is orthopedic surgery areas like fractures. I think that will be covered in surgery, orthopedic surgery. So I'm not going to cover fractures like, skull fractures, mandibular fractures, rib fractures, the upper limb fractures. That I'm not going to cover. I'm going to cover the medical bone diseases. Now, what are these medical bone diseases? Now, in certain conditions, like certain blood cancers, like multiple myeloma. Have you heard of a blood cancer? Plasma cell cancer. Plasma cells called multiple myeloma. It's a paraproteinemia. In this multiple myeloma, you can get punched out lytic lesions. So lytic lesions are seen like black-colored holes. Black-colored holes in various bones in our body. Particularly, you can see that in skull. Can you see in the skull multiple holes here? Can you see these black-colored holes here? Can you see all these tiny, tiny black-colored holes here? Multiple black-colored holes. See the next skull X-ray? It's a better one. You can see these black-colored holes. Multiple black colored holes. These black colored holes are called lytic lesions. You call it punched out, punching out, punched out lytic lesions. You can get that in the skull. You can get that in upper limb bones, like you can get in the humerus. You can get in the radius and ulna. Can you see this patient in the humerus and also in the radius and ulna? Patient has got these multiple lytic, these black colored holes, multiple lytic lesions. So when you get multiple lytic lesions, the bones become very weak and they can get fractured, right? You get osteoporotic fractures because the holes, bone becomes very weak, osteoporotic, and that causes fractures. This is the limbs. And look at this vertebral spine. In this vertebral spine, patient has got severe osteoporosis. Can you see? The bones have become very weak. This is called codfish vertebra. It's called codfish, right? Codfish-like appearance, codfish vertebra. And here you have got a fracture of the vertebra. Can you see? Here the vertebra is like this. It's compressed. So compressing vertebral fractures, there's a medical term for that. What is that? Wedge. W-E-D-G-E, wedge. It's a wedge fracture. So this is a wedge fracture of the vertebra. So this patient with multiple myeloma, he has got severe osteoporosis and he has got a wedge fracture. This is another vertebral spine. Look at this wedging here. This vertebra is completely collapsed like this between these two vertebrae, and this vertebra severely osteoporotic. You can see these white lines, and in between, because what did I teach you? The bone should be completely white, but this is not completely white. Can you see? Only the margins are white. The center is all black. There's osteoporosis. Here, black, white lines, and the center it's very low density. So that means bone is weak. Weak bones are called osteoporosis. So patient has got severe osteoporosis, and this is a wedge fracture. And this is another wedge fracture here, osteoporotic wedge fracture that can cause compression of the spinal cord, and that can cause bilateral lower limb weakness called spastic paraparesis. That day I taught you in my neurology class. So this multiple myeloma, what are the clinical features? These people present with severe back pain due to these osteoporotic fractures, persistent back pain, they get anemia. If you check their bloods, you get very high ESR. ESR will be as high as hundreds, and you get anemia, and they get renal impairment, they get hypercalcemia. If you examine their blood film, you get what is called rouleau formation, like red cells kept one on top, top of each other. It's called stack horn appearance, like coins of stacks, like. So that's called rouleau formation. So to diagnose multiple myeloma, there's a mnemonic. What I want you to write and remember. I hope you guys wrote down important things in this lecture. So that's called the mnemonic to remember multiple myeloma is called CRAB, C-R-A-B, CRAB. C for calcemia, hypercalcemia. A for anemia. They get normochromic normocytic anemia. Right? C for hypercalcemia, C calcemia, A for anemia. R for renal impairment, they get renal failure. Then B for bone lesions. So what are the bone lesions? They get this osteolytic or punched out lytic lesions. So CRAB comprises the diagnosis of multiple myeloma. So when you have a patient with there are many more features which I am not going to teach now because that has to be taught in a separate class. Because the wealth of information that you can give an online class is not as a regular class, that you have to understand. Because you guys are staying at home, I mean, not getting frequent education. That's why we are conducting these online classes, just to keep your morale elevated and also for you to encourage to study. But that doesn't mean that you learn everything which you learn in a normal regular class. That you have to understand, students, right? If you can do like that, then this teaching, your universities, all those are, is a joke, right? Then you don't have to have universities. You don't have to have, lecturers. Right? You can get a robo or something and you can give a recorded lecture. You can't do like that. No one can learn like that, right? So this is just giving you some, heads up, like a morale booster for you to study. So in multiple myeloma, you have this very high ESR, rouleau formation, hypercalcemia, renal impairment. And to diagnose multiple myeloma, you do serum protein electrophoresis. In that, you look for this classical monoclonal band, or what you call M band, monoclonal band in the serum protein electrophoresis. It is not diagnostic, but it only suggests the diagnosis. You also can test their urine for Bence-Jones proteins, BJP, right? So that is multiple myeloma, and these are the X-ray appearances of multiple myeloma. The last slide for tonight, and that's the last slide for your X-ray class. Yes, it's a wide coverage of most important X-ray findings. So when you get a cancer somewhere else, like maybe thyroid cancer, maybe breast cancer, maybe a renal cancer, or maybe prostate cancer, I told you earlier, you can get secondaries. Secondaries you can get in the brain, in the lungs. What do you call that in the lungs? Cannonball metastatic deposits. I showed you the X-rays. You can get in the vertebral, in the bones, vertebral spine, in the skull. There can be deposits. Then you can get deposits in the liver. You can get deposits in the adrenal gland. Right now, these deposits, secondary deposits, some are black colored. They are called lytic lesions. Some are white colored deposits. They are called sclerotic lesions. So I have mentioned in this topic, sclerotic, white colored, or lytic, black colored secondary deposits. So some are black colored deposits, like they are making holes. Some are white colored, they make it whiter. So what are the conditions which cause white color metastatic deposits? What are the conditions which cause black colored metastatic deposits? Now, look at this X-ray. Now, in this vertebral spine, can you see this lumbar vertebra? They are quite white color. These two lumbar vertebra compared to the other vertebra, they have increased whiteness. Here, this lumbar vertebra also, there's increased whiteness. And look at this lumbosacral spine X-ray. Can you see this vertebra? It stands out white. Why is that? That is because there is sclerotic metastatic deposits in that vertebral body. Sclerotic. So what are the cancers which can cause sclerotic metastatic deposits? Yes, the commonest is prostate cancer. So prostate carcinoma can cause these white colored sclerotic metastatic deposits. Sometimes it also can be seen in breast carcinoma and sometimes in lymphoma, but most importantly in prostate carcinoma. Right? Then other cancers, I told you, they produce black colored lesions. That is called lytic lesions. So you see this one. So here, now in a normal X-ray, you have what is called owl's eye appearance. Now look at this vertebral spine. So in this vertebral spine, can you see two eyes? Here, it's one eye, this is the other eye, this is the nose. Two eyes, nose. Two eyes, nose. Two eyes, yeah. Can I say two eyes here? No, only one eye. What has happened to this side? That eye is gone. Then here, yes, there's one eye here and the other eye here. There are two eyes here. But this particular vertebra, there's a problem. You know how to recognize. So two eyes, nose in center. Two eyes, nose in center. This is called owl's eye appearance. Owl's appearance or owl's eye appearance. So two eyes and the nose in center. So that appearance is there in all the vertebra. But here in this vertebra, this eye is present, but this eye is absent. Here, there's no eye here. And even the nose is not there. So that is because patient has got a pedicle destruction. Those are called pedicles of the vertebra. That pedicle is destructed. That is because patient got a lytic lesion. There's a lytic lesion there. Right? So that is pedicle destruction and patient has got a lytic lesion there. So those are lytic metastatic deposits. That owl's eye appearance is lost in that vertebra. And look at this vertebra. Here there's the owl's eye. Bottom one there's owl's eye. But here the owl's eye appearance is lost. Here the eye is present, but here the eye is absent. So there's again pedicle destruction. That's another feature of lytic metastatic deposits following some other cancer, secondary metastatic deposits. So you also can get metastatic deposits not only on the vertebral spine, you also can get them on the vertebra. Oh, sorry, on the ribs. So you can see here on the ribs, there are, I don't know whether you can see that properly, there are black colored lytic lesions. So that is due to secondary metastatic deposits. Right, guys. So all this time, we discuss multiple abnormalities that you can get in a chest X-ray. So we went through a huge area, it's a huge coverage. Notice, guys, X-ray, like there are lots of books written on X-ray medicine. There's a book, you can buy that in the library. You can borrow that in the library. You can buy that book from bookshops called X-ray medicine. But this is not from any book. This is my version of X-ray medicine, very really simplified for you guys. Final MBBS, ERPM, KDU exams. So this is the normal chest X-ray. I taught you how to interpret a normal chest X-ray. Then I went through various abnormal chest X-rays. First, I taught you about pneumothorax, the black shadows. Then I went through the treatment of pleural pneumothorax, clinical features of pneumothorax. Then I went through the white shadows in the chest X-ray, like pleural effusions. What are the clinical features, causes of pleural effusion? What is exudate? What is transudate? How to treat pleural effusion? All that I have taught you. Clinical features, examination abnormalities, I taught you. Then I went through the infections of the lung, pneumonia, the history, clinical features, causes of pneumonia, physical examination of pneumonia. What are the radiological signs, the opacity with air bronchogram, that I have taught you. Then the treatment of pneumonia, pneumonia severity scores, IV antibiotic choices for pneumonia, I taught you. Causes of upper sound shadowing chest X-ray, I told you. Then I went on to discuss about infections which cause rounded opacity with air fluid level or air fluid interface, that is called lung abscess. So causes of lung abscess, clinical features of lung abscess we have discussed, treatment of lung abscess we have discussed, and how to identify lung abscess we have discussed. Then guys, we went on to discuss the condition called bronchiectasis, that is the persistent infection, inflammation of the terminal bronchioles causing permanent dilatation. The clinical features, causes, physical signs, how to diagnose, investigate bronchiectasis, I taught you. X-ray findings, CT findings, like the tram tract shadows, signet ring appearance, finally honeycomb appearance, that we have covered. Then we went on to discuss lung cancers, primary lung carcinoma, how you get the primary lung tumor causing a rounded opacity, like this Pancoast tumor. Pancoast tumor clinical features I taught you. What are the commonest cause of Pancoast tumor? Squamous cell carcinoma. It's an MCQ. Then secondary metastatic deposits, so what you call cannonball metastatic deposits, we have discussed. What is the final procedure to confirm the bronchial carcinoma? Bronchoscopy we discussed. Clinical features, paraneoplastic syndromes of lung carcinoma, how it causes recurrent laryngeal nerve palsy, physical signs of lung carcinoma, all that I have done with you. Treatment also I discussed. Then we went on to discuss heart failure, the types of heart failure, systolic heart failure, diastolic heart failure, clinical features of left heart failure, clinical features of right heart failure, clinical features of congestive cardiac failure, we discussed. Treatment of acute heart failure, drugs with survival benefit in heart failure, I have discussed. So then I went to discuss radiological findings in chest X-ray, cardiomegaly, upper lobe diversion, perihilar shadowing, curly B lines, and pleural effusions, all that I discussed with you guys. Guys, it's not just X-ray, but heart failure lecture I covered with you all. Entire heart failure lecture. Respiratory medicine, 75% I covered in this lecture. Or more than that, actually. Then we went on to discuss certain surgical emergencies that you see in X-ray. Just X-ray, you can see this air the diaphragm due to ruptured viscous and how it's important, physical signs that we have discussed. Perforated viscous causing gas under diaphragm or air under diaphragm. Then we went to discuss another surgical emergency causing intestinal obstruction, causing multiple air fluid levels in the X-ray abdomen. We have discussed, so X-ray abdomen showing multiple air fluid levels. Right. Then we discuss a case of X-ray abdomen showing chronic pancreatitis. There are multiple calcified white shadows across the abdomen, perpendicular to the vertebra. We have discussed causes of chronic pancreatitis. So before the prior to the intestinal obstruction, clinical features I discussed with you guys as well. So chronic pancreatitis causes, clinical features, what is steatorrhea, what are the clinical features of chronic pancreatitis, exocrine insufficiency, endocrine insufficiency, I taught you. Then we discussed about the stones, renal stones, ureteric stones, how they appear in X-ray abdomen, I taught you. The composition of stones, what are the common types of stones, and all the types of stones, their composition we discuss. Clinical features of a ureteric stone, how to treat that, I have discussed with you. Then we went on discuss medical bone lesions like multiple myeloma causing punched out lytic lesions, how to recognize them, the diagnosis of multiple myeloma, the mnemonic to remember multiple myeloma we discussed, clinical features of multiple myeloma, how to investigate multiple myeloma I have done. So that's hematology. Then finally, we also went on discuss what are lytic bone lesions, what are sclerotic bone lesions, that is secondary deposits, how they appear, what cancers can cause these. These are all MCQs, guys. These are asked in the exam. Your ERPM exam is a clinical exam, not a high theoretical exam. You can't just study some notes and study that. That's why you got to come for our classes. You have to learn from a person who knows about this stuff. What they ask in the exam, you have to ask. You have to learn from a person like that. So these our classes, we teach all these things. These are all exam points. MCQs and single best answer questions. They ask all these things. So all that we covered in today's lecture. So I did this now nearly 1.5 hours, more than 1.5 hours. It's 1 hour and 45 minutes. We did this class on X-ray medicine. I think you all will love it. I don't think anyone has even a minute decimal point to complain of. I hope all of you all enjoy this, but learn this art of interpreting X-rays. So when you go towards hereafter, when you go back to the university, learn to interpret this X-ray. I know all over the world students are participating in this lecture from Russia, Bangladesh, India, Pakistan, everywhere students are participating, including our country, Sri Lanka. So all of you all would have benefited. KDU students, ERPM students, local graduates, everyone is listening here today. But I want you to become a better doctor who can beautifully interpret X-rays, who cannot miss an important diagnosis. So I hope my job is done fully. If you like this, you can subscribe. I know all of you liked it. Thank you very much for your patient listening. Thanks.